Good morning, everyone. Thank you for joining Arista MD's virtual conference, Primary Care, the new control center. As Tiffany mentioned, I'm our Chief Client Officer at Arista MD. I'm filling big shoes today because our CEO wasn't available to attend this morning, but you will, during the intermission, hear a message from him. So I hope that you stick around to hear that message. I've spent most of my career working across healthcare operations, um, beginning at a nonprofit maternal and child health foundation. I've also worked with primary health plans, primary care organizations, hospital systems, and I've been focused on one consistent challenge. How do we actually make care work the way it's supposed to? I know there are a lot of physicians on the call today, and I know that you are incredibly focused on making sure that your patients don't run into challenges with access, symptom escalation, visits to the emergency room, or undiagnosed conditions. What I've learned in my career is that most of the challenges we're trying to solve, they're not new, they're structural. They show up in how care is accessed, how it's coordinated, and ultimately by how it's experienced by the patient. Before we get into today's agenda, I want to ground us in something simple. We spend a lot of time talking about models, metrics, workflows. Those things matter, but they're not the value. The value rests with the patient. If what we build does not result in a patient getting faster access to care, clearer direction, better outcomes, then we haven't solved the problem. We've made the system more complex, more expensive, more difficult for our clinicians, and more expensive and difficult for our patients. Today, the reality is we're still asking patients, often elderly patients, to navigate a system that was not designed for them. We see delays in specialty access. We see fragmentation from providers. This is feedback that I receive in my role every day from PCPs. They refer out. The specialist provides a treatment plan. They receive nothing back. And then they have to rely on the patient to communicate what they heard from the specialist. It's not an effective way to deliver care. Primary care teams are carrying the burden of delivering holistic patient care without the tools they need to do this effectively. That's not scalable. It's not scalable for patients, and it's not scalable for providers. That's exactly the problem Arista MD is trying to solve in collaboration with our customers. When we entered the market about 12 years ago now, we started with a very focused objective. There was a clear bottleneck in specialty care. We all know there's a shortage of specialists, and they're unevenly distributed across our country. So patients were waiting sometimes months for access or having to drive to a major urban area to receive specialty guidance. And primary care providers were making consequential clinical decisions without specialist input. As we know, PCPs have to know a little bit about every specialty in order to treat the whole patient. What they can't be expected to do is stay on top of every new evidence-based, value-driven change or recommendation within each specialty and the myriad of conditions that exist under each of those specialties. So we introduced e-consults to help those PCPs stay on top of what they needed for their patients in terms of information and make sure that they were delivering the most evidence-based current care plan to treat that patient-specific condition. It was a way for primary care providers to access board-certified specialists advice fast. It allowed them to make more informed decisions and use the information that they learned from those specialists to avoid defaulting to unnecessary referrals. And that worked. But what we learned was that delayed access was it's just a tiny part of the issue. The deeper problem was fragmentation. Care wasn't coordinated. It still isn't coordinated. Data wasn't flowing, and it still isn't flowing. And patients are still moving through a system that unfortunately often operates in silos. So we evolved, as we know you are as well. Today, Arista MD operates a specialty care clinical organization. We call this Specialty Care 360. We've moved beyond point solutions to offer an integrated model, one that we built with advice, guidance from you, one that brings together care navigation, care delivery, care support, performance oversight, and I think a critical one for our aging population, care navigation. It's all in a single coordinated approach. Because improving outcomes, it does require more than access. It requires alignment. You as the PCP are the center of care. You are familiar and a trusted resource for that patient. Accessing a specialist is often a challenge for the patient. When the PCP stays at the center of care, we see that patients' adoption and compliance with that treatment plan increases. So our focus now is very clear. Primary care cannot continue to function as a passive referral point. Primary care has to be the control center. That means giving providers the infrastructure, the specialist support, the data visibility they need to manage care more effectively within the patient's medical home. When that happens, a few things change. Care becomes more coordinated. Unnecessary utilization, it starts to drop. And most importantly, patients experience a system that works for them. So when we talk about transformation today, and I don't just mean Arista MD, I mean partners and trusted advisors within the industry, we're not talking about theory. We're talking about a shift from reactive care to proactive management, which when I'm talking to PCPs is exactly what they want to do. From isolated decisions to connected systems, from volume-driven activity to outcome-driven performance. And at the center of it all, the patient. We're not talking about it as a concept, but as a driver of every operational and clinical decision we make. Because when the patient experience improves, outcomes improve. And when outcomes improve, patients are happier, providers are happier, costs decrease, and the system becomes more simplified in delivering the care that patients need when they need it. If you want validation that this is where the industry is going, you don't have to look far. Arista MD was recently selected to participate in the inaugural cohort of the CMS Access Model. I'm sure you're all familiar with it, but in case anyone on this call is not, ACCESS stands for Advancing Chronic Care with Effective Scalable Solutions. It's a 10-year initiative from the CMS Innovation Center. It's designed to reshape how chronic care is delivered, coordinated, reimbursed. The direction CMS is moving is explicit. Away from episodic fee-for-service visits towards continuous, proactive, technology-enabled care with primary care teams, specialists, community providers, all working together with shared data, integrated workflows, and most importantly, clinical alignment. What this means for the organizations in this room. The reimbursement environment is shifting to reward exactly the kind of proactive specialty coordination we're discussing today, many of you are already doing. The pressure's on to continue to improve as you move through that continuum. Organizations that build additional infrastructure now and clinical workflows to enhance outcomes and drive that coordination will be positioned to operate inside the CMS framework that we know is the future. In healthcare, there is often a pattern of scramble to retrofit. We don't want to do that. We want to help you avoid that. And I think many of our speakers today have excellent direction, guidance, and insight into how to avoid that. So let me walk you through what today actually will look like for you. We're opening with Don Calcagano, healthcare strategist and Arista MD board member. He will set the context for specialty care system transformation. If you want to understand where the industry is heading and why, Don is the right person to start with. I know this from experience. I have had conversations with him where his insight, advice, and forward-looking thoughts came exactly to fruition, and I hope that you glean just a little of his knowledge and take it forward with you today. From there, Dr. Yulia Jesmir, our beloved Chief Medical Officer, joins Dr. Chris Logar, National Director of Medical Specialties at CenterWell Senior Primary Care, for a session on what digital infrastructure and e-consults actually look like inside an integrated model. This is an inside look at how two organizations are executing, not theorizing, on driving patient outcomes. Dr. Jeff Wessler, CEO of Heartbeat Health, will take us into what scaling specialized care through integrated partnerships looks like in practice, specifically in cardiology. Then, Dr. Ryan Grant from Vori Health will discuss how strategic partnerships are enabling integrated specialty care at scale, with a particular focus on a very expensive specialty that often results in unnecessary procedures and unnecessary testing, MSK. His goal and his organization's goal is to reduce those unnecessary procedures. And we're closing the afternoon with Dr. Richard Stefanacci, Medical Director of Inspira Life, a PACE organization. He brings over 25 years experience in comprehensive care delivery for complex elderly populations and has served as a health policy scholar at CMS. His perspective on value-based care is grounded in both clinical reality and federal policy. And it's the right note to end the day on. Here's my recommendation for how to approach today. Don't just listen to these presentations. Evaluate them against your own workflows. Where are your patients experiencing delays? Where are your providers carrying an unnecessary burden? And where are the gaps in coordination that are impacting outcomes? Use the chat, please. Ask direct, practical questions. Our speakers want to share their experience. These speakers are here to be useful. They're not just here to present to you. And when today is over, take something concrete back to your leadership team. The tools, the technology, the partnerships to build a better system are available right now. The question is how quickly your organization moves to integrate them. With that, thank you for your patience in listening to me today, frame the discussion. And now I'm going to hand you over to one of our experts. To begin our first session, it is my pleasure to introduce our keynote speaker, Arista MD board member and healthcare strategist, Don Calcagano. Welcome, Don.
Thank you, Kate. Good morning, everybody. Thank you for being here this morning. I am so excited to be the start off, the lead-off batter, if you will, for today's lineup of just a host of incredible, accomplished speakers that Kate had just talked about. For those of you that don't know me, I thought a brief thumbnail of my experience and why I'm kind of kicking this off for you all today. So for me, as Kate mentioned, I'm an Arista MD board member. I'm also the founder of something called Values Edge, which is a strategic advising firm. And then previous, and probably more important for this conversation, I have 30 years of healthcare experience. I've been everything from a lab tech to a COO of a hospital, to an SVP of ops for a $7 billion health system. But more important for our conversation today, for the last 17 years, I've been involved in value-based care. Last 10 of those as the Chief Population Health Officer for Advocate Health. And when I left Advocate, put it in context, I was managing 17 networks, over 20,000 physicians, 2.4 million value-based lives, and about 1.6 billion in capitation. So the good news is, well, the bad news is I have no hair, and what hair I do have left is gray. That's how you learn lots of good lessons. But the good news for this is that gives me a lot of context, a deep understanding of healthcare, lots of lessons learned that I hope to inform today's discussions with. And as Kate mentioned, I really hope that we get some good Q&A going. I'm going to be speaking for about 25, 30 minutes and then have about 15, 20 minutes for questions and answers. But the main point you're going to hear from me today is that the value engine in healthcare is the network, right? It's the network. And we're going to go deep on what that means. The pendulum has swung, early 80s, 90s, et cetera. Hey, it's all primary care. We're putting everything on the primary care shoulder. Never mind that they're already working at 150% of the time that they have, but we're gonna have the primary care do it all. And then you can see in some of the more newer models, hey, maybe we should do more with the specialist, and disconnecting the specialist in some ways actually from the primary care. And then, as Kate mentioned, with some of the newer models that CMMI released at the end of last year, let's play a little bit more in the chronic disease space. None of these are wrong. But the problem is when they're disconnected, they're point solutions, you're missing the network effect. And so the point I'm going to make today that I love you all to challenge, agree with, ask questions about is that, yes, these are all important, but as in most things in life, the whole is greater than the sum of all the parts. And that an integrated network with primary care as its foundation is really going to be the driver of great patient care. And frankly, a model our clinicians are excited to get out of bed in the morning and work it. Because that is, if our clinicians are not in a good spot, our patients are not going to be in a good spot. So long story short is it's taken us a while to get to this point. There's a German economist that I like to quote named Roger Dorbusch, who says things take longer to happen than you think they will, and then happen faster than you thought they could. So I think that aptly applies to how we are transforming the U.S. healthcare system. So that's kind of my opening thoughts, but let's jump in. Again, I'm going to spend 25, 30 minutes. I'm going to start with a macro overview of basically what's the healthcare value chain, and then zoom in on more of the network. We're going to spend a lot of time talking about the network. And then I'm going to talk through some of the CMS changes that are really proof points as to how we get there. So let's go ahead and jump in here. I'd like to start with this. So I was a guest lecturer at Kellogg Northwestern a couple months ago, and it just so happened before I went there, I saw this in the Wall Street Journal, and I thought it was very apropos for the students. But the more I think about it, I think it's actually apropos for all the work that we're trying to do. And the point of the article was your investing strategy is great, so as long as you don't actually trade anything. And what this was about is you read all these research studies on investing, and they all say you're going to have these superior returns to the market, all this great stuff. And then when you actually implement the theory, it never works the way it was planned. And so the way I think about it is, yeah, in theory, there's no difference between theory and practice, but in practice, the difference is huge. Meaning theories look great on paper, but the reality is the real world has friction points, things that can't look good on paper, that aren't seen in paper, if you will. And so put another way, General Eisenhower used to say, plans are useless, but the act of planning is invaluable. Or put another great strategist, Mike Tyson, said, everybody has a plan until you get punched in the face. And that's really what we're talking about here, right? That is why we're so privileged to have the speakers we have today, because we're not just talking about things on paper. We're talking about things that are actually being done, right? You can read all the stuff in Health Affairs and all the JAMA and all the other articles. It's the folks that are doing the real work where you have that friction and you've learned through that friction that makes it valuable. And so that's why you're privileged to have the speakers you have today. But we'll also talk a little bit about CMS and CMMI. A lot of people are frustrated with their models, but the thing I love about their models is it's a learning lab. Yeah, it frustrated me from time to time when I was managing my 17 networks. But the reality is, if you kind of sifted through the noise, you learn and you're able to improve your network, you improve your patient care, improve your physician satisfaction and engagement. So now, with this as a backdrop, let's continue going a little bit deeper here. So we're going to start with the value chain. I think most folks are aware. Michael Porter created the term value chain, which basically says that every process step in producing a service or a product adds value. In healthcare, I think that value chain is a little more lopsided, a little more complicated. Because I'm a simple guy, the way I've thought about the healthcare value chain is this is my very simplified version of how healthcare works. Basically, a payer creates a product. They then work with a provider network to provide services for that product. So providers. That product is then offered to distributors. Think insurance brokers. Think benefit consultants. Those distributors then share them with the purchaser. So the purchaser could be an employer, could be an individual, and then the patient or the employee buys that insurance from their employer. So that's a very simplified version of what works. And if you think about the United States healthcare system, the way that this is kind of framed today, every single segment, if you follow Michael Porter, should be adding value. How is the payer adding value? How's the network adding value? How's the distributor adding value? I think many of us could probably pick this apart, and we're not even adding pharma or medical devices or the other pieces of the value chain here. But we can pick this apart and really question, does each link add value to the final output? And the other thing I like to point out in my simplified version is notice the patients at the end, right? So it's not patient-centered in many ways. But I think the bigger problem is the quote I have on the bottom here. If you're familiar with Edward Deming was a quality guru that really helped the United States catch up to Japan in the 1900s. And he's got some great writing, some great books. But one of his whole points is that if you want to optimize a system, you have to sub-optimize the subsystems. Meaning, if we see this value chain as the healthcare system, we have to sub-optimize the payer's point, the network's point, everybody's point. Because if everybody optimizes themselves, then at the end of the day, the system will be sub-optimized. And I believe firmly that where we find ourselves today is that we're sub-optimized because there is very little trust amongst the links in this chain. There's very little coordination amongst the links in these chains. And so that's how we find ourselves where we are today. And we're going to spend a little bit more time getting into the network in a little bit, but let's go a little deeper in what's going on in a U.S. healthcare system here. So this was an article in JAMA 2025, tracking U.S. healthcare spending by health condition and county. Highly recommend. It's a good read. What's interesting about this article, I'll call out a few things. First, the little yellow highlight, if you see, this is a little bit older data, 2019. And I picked this because it was prior to the pandemic. Because as you all know, once you get into 2020 through 2023, 24, there's a lot of different dynamics going on. So this is a little bit more about where the steady state was. The reference is on the bottom, but the other thing I want to call out on the bottom is the way the study was done. They got over 40 billion insurance claims, 836 million hospital admissions and visits. It's roughly speaking, probably about 50% of the healthcare in the United States. So it's a sample. And so are these point estimates? Yes. Are they directionally correct? Absolutely. Large sample size, I very much believe what's on here. But just to orient you to what the slide shows, on the top part here, it's the type of care. So is it ambulatory, which includes physician visits? Is it inpatient, pharma, AD, et cetera? And then it shows you what the spend is. And then it shows you what percent of the total spend is made up by those types of care. And then to the right, what you see is between 2010 and 2019, how much did that expense grow? And then the next column over is that growth adjusted for inflation. And then further to the right is that growth per beneficiary. also adjusted for inflation. So that's kind of how you read this. And then on the bottom, it's a little bit tangential to what we're talking about here, but also talks about, if you look at it from the payer type, what's going on as well. So a couple things catch my attention always when I look at this. A lot of emphasis has always focused on hospitals, the inpatient care. And that makes a lot of sense, the inpatient care, because right, if you've all received hospital care or been a customer, it's expensive. There's a lot of reasons it's expensive, right? On Tala, it's open 24/7. Depending on the level of trauma, they need to have certain things available. They buy big machines like CAT scans and MRI. So lots of reasons it's complex and expensive. And look, I used to be COO of a hospital. There's no doubt hospitals can be more efficient, no doubt about it. But if you look at the end of the day, the inpatient component of healthcare is only 24% of the total spend. You look at the ambulatory portion, it's 42%. Now, that ambulatory will also include hospital outpatient departments. So hospitals are part of that as well. And then pharma is 14%. And I think we're all aware pharma's been growing a little bit more. So the reason I call this out is we're talking about networks today, primary care and specialists. A lot of that makes up that ambulatory piece. And I don't have the charts in front of me here today, but if you look at it, the specialty growth has been growing really, really fast. And I'm going to argue that with our better network, that growth would be more appropriate and ensure it delivers higher quality. And then if you look at the little blue box, this is the spending growth. Again, on the chart here, you see emergency rooms are the fastest growing at 6%. Ambulatories, not only the biggest percent, but growing the fastest at 5%. And then home health is growing at 5%. And I'm actually encouraged that home health is growing faster, because one of the measures we used to measure is patients' time at home. Because I do believe more care should be done in the home. It has to be made sure it's safe and all that good stuff. But I think that's actually a positive note. And then just tangential to today, and just want to call out on the payer side where you see my red circle, cost shifting remains a problem, right? So you see that the private insurance spending, so think employer-sponsored insurance, is 3 to 5 times what the government per capita growth is. And this is obviously because the government has governors in place that actually reduce how much those costs go up. And so the expectation of private insurance goes higher, which then causes employers to pay more, patients, beneficiaries to pay more for copays, cost shares, et cetera. So that's not our topic today. I think we do our job and do better with our networks, then ultimately that growth rate can come down. And more importantly, I would argue, the quality goes up. So one of the things that was super interesting and important when Congress was trying to think about the ACA and, hey, how do we improve healthcare? They kept talking about bending the cost curve. Most people aren't aware, but Brookings recently had a report that shows if you look at the national health expenditure, which is probably the closest thing we have to the source of truth on how much we spend on healthcare. If you look at that blue line, that's the actual spend in the United States from 1960 to 2024. You look at that dotted yellow line, if you were just drawing a best fit curve, that's what we were expecting the actual cost to be. But you notice starting in about 2010, that line did start to bend. And so the Brookings piece, if you haven't read it, it's cited at the bottom. I think it's a very good read. It does make you ask yourself a lot of interesting questions. But make no mistake, we have started to bend the cost curve. We spend $5 trillion on medical care, though. So while we've started to bend the cost curve, we're not where we need to be yet. In fact, we're at about 18% of GDP, which is up from 17.2% in 2010. But it is $1 trillion less than where we thought we would be. Now, if you see the footnote at the bottom, if you compare us and rack and stack us to other advanced economies, they're all running around 12%. Now, you could argue lots of things. Oh, they do more on the social networks, or their waiting list to get in is longer. Like, they 12% may not be the best benchmark, if you will, but it's what we got. So the good news is we're starting to bend the cost curve. The bad news is we're not quite there. A lot of this cost curve, if you read that report, has been, quite frankly, site of service shifts and improved technology. Patients are able to recover faster and outside of the hospital. They're able to be cured versus just managing their symptoms, things like that. So, good read if you haven't had it. But one of the things I like to focus on is I think too often when we talk about value-based care, we focus on the payment mechanism. The reality is value-based care, the common definition is what is the benefit for the dollar I spend? So numerator is benefit, quality, safety, et cetera. Denominator is spend. We spend way too much time talking about the payment mechanism. I think we need to spend equal amount of time talking about the quality side of things. So if you just look at the NCQA data, the point I want to make on this chart is over that same time period, 2010 to 2019, we've seen considerable improvement in lots of quality metrics that the NCQA measures on the Medicare Advantage side. And we've pretty much been flat on the commercial side. And there's lots of reasons for that. But what I want to point out here is I think everybody's aware of the way Medicare Advantage is set up. There is incentives for providers, not just clinicians, but the health systems and others that are part of the networks. They're incented to do better on screenings, on hemoglobin A1C control, on blood pressure control, et cetera. So you see on the left side of this chart that we have seen improvement in those metrics versus on the commercial side, it's been fairly stagnant. One thing I really want to call out here, though, and I used to talk with my physicians on my boards about this all the time. Even on let's take the hemoglobin A1C going from 63 to 73. Looks like a great improvement, which is great. And that's just the average. But that means that there is still 27% of the people that are not in control, diabetic patients that are not in control. And even if you look at the top performing, top decile in these numbers, what you see is we still have 15, 20% in some cases of patients not being in control. So we've made great progress, but we still have a long way to go to get to what I think we would all expect for ourselves and our family members. So thrilled that we have progress, but my point on this slide is the model does matter. And we'll talk a little bit about the CMS, CMMI programs a little bit. But I mean, frankly, what you're going to see is because of that healthcare spend putting so much pressure on employers and purchasers of healthcare, I think you're going to continue to see more and more focus on models that are not just pure fee for service. I don't think they're going to be the complete value-based care chassis that we have today. I think those are going to continue to evolve, but it's not going to remain just a fee for service world. And to that point, we're not going to talk about this today, but really the term value-based care is something that drives me a little bit crazy, quite honest. If you think about how an organization works, every organization has a governance model, an operating model, and a business model. The governance model is, hey, what's the strategy? What are we going to do? The operating model is what we actually do. And the business model is how we get paid. At the end of the day, the problem we have in healthcare is what the operating model does versus how it gets paid, right? The operating models are really built when you look at these big expensive hospitals and other things on this fee-for-service chassis. The more units, the more widgets, the more people, the more things we do, the more we get paid. But the business model, the people paying for it, they want, like we talked about, higher quality, safety, et cetera. And so it's that disconnect between the operating model and the business model that gets us in the space we are today. So I would argue vociferously that gap between operating model and business model is going to be closing. You saw the beginning of the bend in the cost curve. I don't think it's a mistake that started around the same time that we started doing ACOs and more pay for performance and things like that. So that gap's going to close. The alignment's going to get higher. So for all of those of you attending today, I think you got the great seats because you're looking at people that are doing the right thing ahead of the curve. And so as these models change, if you adopt some of them, you will be in a better position, so you don't have to try to turn the Titanic very quickly. And one of the things, I think everybody knows Don Berwick, a physician that had led CMS for a while, but he's pretty famous for saying every system is perfectly designed to get the results it gets. One of the things I like to point out as we go through this value chain and talk about this, if you were to design the healthcare system from scratch, someone gave you a blank sheet of paper and a magic wand and said, hey, design what the healthcare system looks like. Would any of you design it the way it is today? I can't think of very many people that would. And so our challenge is, how do we transform that healthcare system where essentially we're driving a bike at the same time we're trying to change a tire? So it's harder work, but I encourage you to think about what should that better mousetrap look like. All right, so that's my Don's Simple Economics 101. Let's jump into networks a little bit deeper. Those of you who have heard me say it before, I am a firm believer that the value of healthcare is the networks, right? That's where you have the clinicians, the physicians, the APNs, you have the hospitals, you have the post-acute networks. These are the folks that are providing value. And I would start with, we throw the term network around all the time, but what are we talking about? And so if you just look up network on a dictionary, it's basically a large interconnected system consisting of multiple similar or related parts that are linked together to allow for movement, communication, or sharing of resources. All right, that seems to make sense. I think the most commonly used network that we all know is our cell phones or the internet, right? Our cell phones work, doesn't matter if we're in the United States or if we go to the Caribbean for vacation, somehow they still work, right? The internet, when we jump on the internet, 99.99999% of the time, it works. I can go see anything on the internet. That's because it's an interconnected system with related parts that are linked together, so we can share things. And characteristics of a network are, first, you have nodes. So think of these as the people or the entities within the system, cell towers, DNS servers in the internet. But then importantly, you have links that connect them, right? The data, so it's the fiber between cell towers. It's the fiber between DNS networks and the internet. There's these links that connect these nodes to each other. And then most importantly, there's a protocol. There's been a standardized way that communication is sent across. So if it's one DNS server talking to another, they use the same protocol. If I type in my hyper text language into my web browser, that's a standard. Everybody knows how to interpret it. My AT&T switches over to a Verizon tower, to a T-Mobile tower. They have a standard way of talking, right? So networks require rules and structure, et cetera. So my question to you is, when you think of the provider networks that we're working with, do they fit these criteria? Right? If you were to advance these concepts to the provider networks, I would challenge you that I don't think we're there. We are in some use cases, but I think as a industry, we're not. And one of the things that I like to bring up when I think about this is, are all networks equal? So on the left, and if there's anyone from the insurance side of the business, don't take this personally, is the insurance company saying, look, I created a network. On the right is the CIN or the ACO or the IDN or the large risk-bearing entity. No, we created a coordinated network, right? They both create networks. I would argue, and when I was negotiating with large insurance companies, I used to tell them this all the time. You don't create networks. If you take two IDNs and stick them together, that's not a network. Just think about the definition that we just walked. But if you actually work with a CIN or an ACO, if you be able to put those nodes in place, those protocols in place, you're creating a network. The reason I think that's really important for everybody here today, what we're talking about is creating networks. Primary care is the foundation, but not enough time has been spent on what are the right specialists? How do we work with them? What are the protocols? And that's where Arista MD really comes in really hard and fast, I think, is helping with that piece of the network. So this just came out literally like 2 days ago. So Health Affairs, an article about payer-provider partnerships for specialty care must use health outcome data as their North Star. So just a couple things I want to call out. It's a really good article if you haven't read it, and if you're really focused on networks and specialists. This obviously is focused on the provider, if you will. But at the end of the day, it makes a couple of points I think are very germane to what we're talking about. In specialty care, there's often no single quarterback coordinating care. And that causes a problem. So think about what we were talking about today, how some of these virtual solutions can fit in. Think about how Aristas fits in, et cetera. And then the second quote is, access delays in specialty care are well documented. We have got to figure out how to free up access. I think virtual, digital, a lot of what you're going to hear today is part of that solution. Again, I have the quote or the link reference on the bottom. I highly encourage you to spend some time on this. All right, so let's talk about networks. If you imagine, I think about pendulums, I think about dials. If you imagine a dial that said, hey, we're going to really amp up the primary care, or we're going to focus on the specialists, or we're going to land on a network. I think in the 70s, 80s, 90s, 2010s, we always thought it was primary care, right? Primary care, primary care, primary care. I don't think primary care is the full solution to providing value. And I think there's lots of reasons that I believe many people would agree with. Primary care is a very, very, very busy specialty, right? There's a lot of things they can do. There's a lot of things they don't have time to do. I think team-based care, patient-centered medical homes, these things are making it more successful, but it's also leading to burnout in some of our primary care docs. So our primary care docs have to be the foundation to the network, no doubt. And even the title of what we're talking about here is we need to be able to really talk about and share the fact that, hey, primary care is going to be coordinating the network. And it may not be them directly, it might be the risk-bearing entity, their CIN, their ACO, but they are core to the whole piece, but they are not the solution by themselves. And some of my proof points of that is, again, if you spend time thinking about CMS and CMMI, again, I think people get so frustrated with their models, but they forget about the fact that they're doing a great job of telling us what doesn't work. You know, the old Thomas Edison quote of, hey, I tried 1,000 things that didn't work. Well, they're helping us learn. And I know it can be frustrating if you're in the middle of it, but we do have a lot of lessons learned. And, you know, primary care is still the front door, the foundation of value-based care. CMS has repeatedly shown that it's able to improve access, care management, follow-up, and in some cases reduce utilization, right? So they do have some models that have been successful. But I think the overarching point from the models that I've seen there are, frankly, that standalone primary care models don't consistently generate the savings that are necessary, right? That they're only a start in the direction of where we need to go. So again, very important. And we could go through any of these models and talk about some of the findings. You know, some of them were canceled, et cetera. But generally speaking, I think CMS has proven to us that primary care alone is not sufficient, that we need to think more about networks. So then I kind of feel like networks swung all the other way, like, hey, networks are about the specialist. And you see that CMS also created some models for us to look at there. And this one was a little more interesting, right? Specialists showed that if you focus on a defined episode, and so it's that defined episode, it's a recovery window, it's a post-acute, they've been showing that some of these specialty care models do work. But when you get into the disease specific, like kidney care and oncology care, so some of those models, frankly, have mixed results. So the episode-based specialist models do reduce spending in a broad sense, but disease specific have been tough to reliably say work. So bottom line here is, yeah, specialists are important. Having the right models for them is important, but much like primary care, it is also not sufficient. So I think at the end of the day, where this leads me is, hey, networks are about networks, right? It's not the primary, it's not the specialist, it's actually the network. And as we talked before, networks go way beyond just primary care and specialists. They include hospitals, they include SNFs, they include ASCs. But for what we're talking about today, we're really focused on primary care and specialists, though I will give you a little bit of a look at some of the hospital stuff. All right. So when I think about what CMS has done in the network space, this is really their ACOs, right? Because very few ACOs are standalone primary care. And so, they've done the MSSP, the Pioneer, the Next Gen, they've done direct contracting, they've done REACH, you've got a couple all payer models, and then you've seen the launch of LEAD, which I think LEAD is a very exciting model if you haven't spent time thinking about it, because it builds on everything we just talked about on the primary care, on the specialist side, et cetera. I think it is their most advanced model. Time will tell if it's the right model. These things are complex. It involves benchmarks, risk adjustment, attribution, payment flows, governance. They're complex. But I do think LEAD has really built in a lot of the lessons learned over time. And so if you think about it, primary care influence the front door, specialists influence high cost episodes, but it's really the networks that control the value chain within the actual care being delivered. And then last thing I'm going to end on this is, at the end of the day, what about the hospitals? Like, we started by saying hospitals are part of the big spend. This is tangential, again, to what we're talking about today, but hospitals are part of the networks. You can't exclude them. A lot of people believe they're going to become cost centers, and I kind of believe they're going to become more ICU-like, if you will, over time. But if you haven't read the 2026 Outpatient Prospective Payment System, so how CMS pays hospitals for outpatient care, very exciting read. I highly recommend it. Get it late at night. You'll sleep like a baby. Within there are a couple of key points around site neutrality. And we won't go into details here, but basically site neutrality means you get paid the same if it's done in a physician office, an ASC, or on a hospital campus. Hospital outpatient departments make a lot of their money on services done on their HOPDs. So this is a big shot across the bow to hospitals. And then add on what's going on with Medicaid, ACA subsidies, a lot of these things that'll create bad debt for the hospitals. Hospitals got the tsunami coming. And I think, as it is germane to what we're talking about here, where specialists do their work will be changing. We're going to talk a lot today about digital, virtual. ASCs are going to be in there. So just the reason I thought it important just to round out our conversation on networks is where our specialist practice is going to be part of what changes over time. So with that, very quick overview of my view of the world, but I'm super excited for the folks you're going to hear from today. You're going to hear about digital infrastructure as the foundation for scalable specialty care. You're going to hear about integrating virtual first cardiology. You're going to hear about integrating virtual first to reduce unnecessary ortho. So I think it's a great lineup today that's going to talk about many of these challenges that I laid out for you. And one of my favorite quotes that I like to end with is, if the path before you is clear, you're probably in somebody else's path. So again, I encourage you all, if you were to create, using a blank sheet of paper, what the world should look like, you would probably not have the system we have today. So I encourage you to get out there and keep transforming. And I think the speakers you're going to hear from today are really going to help set up for you like how you should think differently.
Don just gave us a masterclass on the integrated advantage and why systems as a whole, the governance, the business, and the operating models must align if we ever want to move past the frictions that cause so many great theories to fail in practice. One thing that he made so clear for a network to truly perform, we have to stop looking at its parts in isolation. I am going to transition out, but thank you so much, Don, for the session. We appreciate it so much. And we are excited for our next session that we have going on. As every PCP in this room knows, there is a massive difference between a strategy on a slide and the reality of a 15-minute patient visit. Historically, primary care and specialty care have lived on two separate islands. On one side, you have PCPs managing longitudinal relationships but lacking early access to specialty thinking. On the other side, you have specialists focused on episodic depth, often entering the story only after a disease has already progressed. Between them, we've relied on a transactional bridge, the traditional referral. As Dawn hinted, the future is not just about making that referral faster, it's about making it unnecessary whenever safe. It's about shifting from a model where we hand off the patient to the one where we share the expertise. To show us exactly how that is happening on the ground, I'm thrilled to introduce Dr. Chris Logar and Dr. Yulia Jesmer. They are going to walk us through a blueprint for integration. They aren't just talking about abstract coordination, they are presenting the actual digital infrastructure and clinical collaboration model being used by Arista MD, CenterWell, and Conviva. They will explain how asynchronous consultation, starting with an e-consult, is becoming the first move in the clinical narrative. This isn't just about efficiency, it's about a fundamental shift towards PCP-led, specialty-informed decision-making. They'll show us how we can standardize pathways, create explicit clinical guardrails, and ultimately allow PCPs to manage broader clinical terrain with total confidence. Please join me in welcoming Dr. Logar and Dr. Jesmer to the stage to share the blueprint for the integrated future.
Wonderful. Thank you so much, Tiffany.
Thank you so much for the introduction, and it's so wonderful to be here with all of you on this Friday. It's just like we've added people to our one-on-one, Dr. here, and so we can share how we normally spend our Fridays together.
I love it. Thank you everyone for being here. We are very excited to share what we have been up to for the last few years. And I'm Yulia Jesmer. I'm the Chief Medical Officer at Arista. And Chris?
And I'm Chris Logar. I'm a nephrologist internist by training. I'm the National Director of Medical Specialties for CenterWell, the primary care side of the organization, so the largest provider of senior-focused value-based care for our Medicare patients. And I'm going to start off, I think. Does that work?
Please kick us off.
Awesome. So we're going to share our experiences. We have been collaborating for the past few years, and the goal and the journey that we're on is to integrate specialty expertise into modern primary care. And this is a significant change in behavior and culture for primary care specialists and for patients. So in the past couple decades, we know that the fee-for-service reimbursement system has forged expectations for patients in primary care. Like, patients go to their PCPs requesting and expecting referrals, and then they anticipate the referrals to happen from the PCPs, and then they go to the specialist to get their answers. And this is a system that's designed to be operationally very efficient in the fee-for-service medicine, but it turns out to be terrible for patients, for specialists, as well as for primary care physicians and non-physician providers. So although the care model is different now in value-based care, the true change from fee-for-service to value-based care is going to require us not just to add tools and resources, but we have to call out this broken baggage that we're bringing from fee-for-service medicine and recognize that we're changing the language, we're changing the culture, and ultimately changing behaviors while we rebuild confidence for patients in primary care's ability to deliver holistic, full-service primary care services. So I am going to kick us off. Oh, I had it up. There we go. Okay. So the separation between primary care and specialty care is a direct consequence of these payment structures that did not reward or support integration. So the RVU payment models have applied this pressure and caused this evolution or devolution of specialty and primary care differently. So each optimizing for different goals. And where we started historically was primary care was built around longitudinal relationships and holistic and broad clinical judgment. And specialty care was designed around depth and episodic evaluation or procedural skill set or discrete problem solving. But over time, due to the fee-for-service evolutionary pressures, we saw primary care evolve to protect access and increase throughput. So it was forced to narrow scope of care in order to achieve these objectives, right? We can't do everything for everyone all of the time. At the same time, specialty care is trying to absorb additional decision-making, but still in an episodic and disconnected way. And clinical care coordination was assumed to happen kind of in the in-betweens, even though the system was not set up nor reimbursed to support that. So patient care became fragmented, and patients and caregivers were left in the in-between. So in most communities or health systems, I'm sure this is it was true where I worked in Seattle, it may be true in your communities, primary care and specialty care function is highly optimized, but very disconnected islands. And this became increasingly unsafe for medically complex, frail, and aging population. As a risk-bearing entity in Medicare Advantage at the primary care organization, we are clinically responsible not just for the clinical outcomes of our patients, but financially for the total cost of care. And to be successful, we have to solve for this two island situation. And then to solve for it, we want to understand really kind of how we got there, what drove island formation, and then what also this we can actually control. So we hopefully have some control on the primary care side, so we can start addressing factors like time scarcity, right? So we have smaller panel sizes for our PCPs. We give them more time with their patients. We can start to solve for this really broad responsibility that they're assigned by growing programs to support PCPs in care management, add additional resources to support holistic ownership of patient care. We can try to account for them having to reach outside our four walls and be accountable for the full patient clinical journey by growing relationships with hospitals or SNFs or specialists. We have to find ways to influence all the locations where our patients receive care and walk beside them while they're receiving that care. And finally, we have to figure out how to move upstream with them so our patients are connected earlier to specialty care before disease progresses and become irreversible or becomes a late stage. So, and we have to also do all of this with things we can control within a primary care, right? We have to respect the scarcity of specialty care. So unfortunately, when we're still interacting with a specialty system that remains deeply embedded for the most part in fee-for-service medicine, it's subjected to that model as well as that mindset. Until we're able to bring full value-based care to specialty, that's the reality. We can only change the island we're on. We cannot change the other island. So what we have right now is a system that is trained to over-refer and under-manage. And for patients, the separation results in at baseline multiple appointments, each of them scoped very narrowly. Patients often get conflicting recommendations without a clear path towards reconciliation, right? My cardiologist says X, my nephrologist says 72, my endocrinologist says zebra, like we're not even talking the same language. And this results in delayed decisions while the patient's conditions silently progress. And this poor communication requires the patients to be that boat, that integration between the islands. They're navigating access, they are deciding whose advice matters the most, and they're carrying information. So if primary care asks the patient, what did the neurologist tell you? I would love for that to be an assessment of understanding and engagement and awareness and healthcare literacy, but instead it often is because the PCP doesn't even have the records from the neurologist that are literally asking like, what happened at your specialty visit? So current state, we now are sitting on our islands. There is a bridge. The healthcare system has one bridge for us, and that's the referral. But that referral is not really built to enable early thinking or interventions. It's not there to support co-management. It's not there to share really uncertainty. So if there's any specialists here, I want you to think about how you would feel if someone sends a referral that says, I'm not 100% sure exactly what's going on in this patient, or have I done the adequate workup for this patient's problem, right? The current referral structure is very, very transactional, and it doesn't allow for working in a different space where there's uncertainty or need for bidirectional communication. And I see this all the time working within the value-based care system. And this is what Julia hears about me when I rant about the problems we see in the traditional referral. And the basic kind of clusters, like there's this timing problem, right? So referrals occur late. They're like fire alarms way too late into the house fire. Disease has progressed. We may have said, I'm going to watch this for a while before I refer you to the specialist, or you're not quite sick enough to go, and we see this in nephrology. We're going to wait until you have CKD4 and then we're going to refer you to see nephrology. So time has passed for prevention. Referrals happen after management decisions have been attempted or deferred. There's a signal problem, right? The PCP has 100% of the ownership for defining the problem in order to ask for help, which is really inherently flawed. And it also gives a specialist an out. Like, I was only asked to solve for X, even though there were 72 other things they could have looked at within their organ system while the patient was there. And this is not to throw anybody under a bus. This is just how the system has evolved, right? And this is the ownership problem, right? The referrals are viewed as a one-way transfer. Once the referral crosses the bridge, on primary care, we assume that specialty care has the capacity, structure, incentives to take ownership of everything that comes next. But in reality, as a specialist, I didn't have access to any more care coordination systems. So sending me a complex CKD4 patient does not ensure that that patient is going to get better care management or care navigation than they would from a primary care office in a fee-for-service system. So that is like the reality. And this doesn't have to happen this way. Like, for most diagnoses or many conditions, a full transfer of ownership is unnecessary, and especially is not, as we said, not resourced to provide comprehensive care. And in my population, a high-risk elderly population, this is especially dangerous. So these small delays compound and these add up and become more complex more rapidly in a frail population. The risk for medication misalignment increases with rampant polypharmacy, and someone is managing this somewhere is, an unsafe assumption. So the challenge today is really not about who should own more. It's really about how ownership or knowledge or expertise can be shared earlier, intentionally, and more safely. And that then we want to then ensure that this step up earlier then starts to reduce downstream pressures on an already overburdened system. So the goal here is really to improve outcomes by starting earlier and then avoid some more heavy lifts that happen later. So we're shifting towards this future ideal state. We're building an earlier intentional model of shared decision-making. We want primary care to remain in control, and especially to provide structured educational support. And there's sharing there. It's sharing in the decision, though, about when a patient needs to leave primary care to get specialty care. So this is a shift in how and when knowledge or expertise is requested as well as applied. So this is not about blocking referrals, or, like I say, I'm not fact shaming primary care. We need to provide a platform for PCPs to be able to ask earlier in like a safe environment, like, does specialty thinking need to be involved now? And at what depth? And this is a shift from a transfer, like I say, I'm not donating a patient to you, or a transfer of care. This is collaborative decision-making. So shared ownership does not mean that primary care is working outside of their scope, or that there's blurred lines of accountability or responsibility, or that we need specialists less. It's just different. So in an ideal integrated model, the specialist thinking enters earlier. It's going to bring insight to uncertainty, and primary care retains full ownership of the patient journey within their scope of practice. And so this is where specialty is kind of providing the guidance, the guardrails, and like, when do you escalate? I think a good example of this, and we're going to talk about this more, is our eConsult First initiatives, right? The goal is to lower the barrier to trying something different and new, right? If you say everything routes to an eConsult first, that normalizes that earlier intervention. It removes the stigma of having to decide when to ask for help. Like, it just becomes normal to say, I'm not really sure what's going on here. I think I need to ask a question. And it teaches you how to use the model through repetition, right? Again, we all train in fee-for-service medicine. We all have to learn to use these tools differently. And sending everything through eConsult First is, again, not about blocking or stopping. It's about creating a safe, repeatable moment for adult learning. And then the digital infrastructure starts to support this and makes this easy to happen. So we're going to talk about how we did this and how digital infrastructure is the enabler. there has to be an integrated easy button, which enables PCP within the PCP workflow. Like that has to be done in order for this to be effective. And digital infrastructure it's a foundation. It's like that platform on which this new care model can exist. Like this is what, maintains the ecosystem that allows specialists to safely extend back into primary care scope, and how specialists can be present, connected. You have to build trust between primary care and specialists for this to really work. Technology supports this new clinical operating model, but at the end of the day, we're humans taking care of other humans. It's people, process, and tech. So digital infrastructure has to be combined with value-based care workflows and a value-based care mindset and a willingness to try something new and different and feel supported in that process. So this is a platform upon which these different clinical conversations can be held safely without increasing visits, without increasing cognitive load for primary care or specialty. So I think about digital infrastructure as a set of workflows, data structures, and accountability rules that are built on shared trust that allows primary care and specialty care to work together and think asynchronously. So I want to set up Yulia here to talk directly about our collaboration and what we learned. And I'll just start with, I think this is my last slide, to kind of start with the basics and set her up for her part of the talk. The process has to fit into real clinical workflows. And I think we align that there are sort of 4 critical capabilities that have to be established for asynchronous workflows to succeed at scale. So the first is a shared clinical context, right? So value-based care is about longitudinal care. It's about that clinical storyline. And e-consults will support this when specialists work from the same sort of clinical narrative, the same story, which is owned by the primary care. So in our model, specialists are not, they're not generating parallel care plans. They respond to primary care's framing of the problem and the clinical scenario. They live on content from our EMR, and this requires a good summary of the clinical story and a really good clinical question. This is what I need help with, has to be clear for everybody to exit that asynchronous event with the next best step for their patient. Unfortunately, in most modern clinical content, the EMRs, it's fragmented, it's poorly suited to tell the longitudinal story. So we've seen meaningful improvement by addressing this upstream through both education and some tooling. So from an education perspective, we have to focus on teaching how to ask a better clinical question. And I know that Yulia is going to talk about this more, but for clarification, your physicians and non-physician providers don't wake up in the morning and say, I want to intentionally ask bad questions. Like nobody does that. But the system, and specifically traditional EMRs and how they're structured through a referral ordering process, it's designed to make a referral fast and easy in fewer clicks, right? That's how we said value was, I had to do the least number of steps to place a referral, make it as easy as possible. So you have to figure out how to restructure your EMR's referral ordering process, or understand where you can influence that to make it easier and collaborative, so that you can find a way to not like I say require a mandate, but create space for that clinical question to exist in a way that it is clear. The second thing that actually just heard the last speaker talk about is in-office generative AI. When PCPs use generative AI, we use Abridge to support like telling and summarizing the longitudinal story, the quality of your asynchronous consultations improve. So I do our clinical audits for our e-consult, and I read a lot, and I could see this change. And what changed wasn't primary care's intelligence, right? It was the clarity of the shared content. So this part of digital infrastructure helps sort of translate the clinical knowledge or the clinical event or the experiences happening between the PCP and the patient into a usable narrative by improving documentation that then is shared with the specialist. So I think that creating and working on your shared clinical context is a really important first step to generating value and needs to be supported by your structure. Number 2, standardized pathways and curated panels. By standardize, I'm defining here saying that we have to create an easy and reproducible, low friction, safe way for PCPs to kind of explicitly signal uncertainty. Like it's hard to say, I'm not sure about this, or what am I missing and what is the next best step? We have to be able to signal around decision points or questions of appropriateness. Like, I think it's hard to say as a clinician, this is what I did, and was this the right thing for the patient, or should I have thought about this differently? It's hard to say, like, identify, I think, emerging risk. That's not a place where many of us know how to ask questions. Like, it's hard to say there's nothing wrong today with this patient, but I think this patient is at high risk for a really bad thing in the future. And instead of waiting for it to happen, what can I do to prevent it? Right. So again, being a nephrologist, I love nephrology examples. That's when people are like, why would I ever refer a patient like with CKD1? And I'm like, well, 1 or 2. If they have 6 grams of proteinuria, that's an evolving risk. We want to get to refer for risk, or at least ask a question. What can I do to mitigate this patient's risk, even though their GFR is still 95? So those are all things that you have to try to bake into a standardized process. And operationally, you can support this with an e-consult first pathway that still uses the referral as the communication vehicle in the EMR. But for example, if you automate and bypass your referral coordinators, right? What you're doing is you're signaling that, and you're creating a path for PCPs to move upstream. Like it does, you're creating a bypass route that you can show them visually, even though you're using the same referral order as the tool, for example. So I think the pathway is really important to kind of understand that you have to differentiate it functionally from a traditional referral. And the digital infrastructure is going to support this. So like e-consult first strategies that are baked into your system are going to make it easier, low barrier, and structurally, you got to make it visible and intentionally. Like it's visible intentionally as a pre-referral step, not as a gate or a guard or a barrier, right? So there's a difference in how you do that in your system, or you educate or you speak to that. And then second, the curated specialist panels add to this safe space. So Arista links very specific specialists to specific markets to build a trusted relationship. So, and that's going to then build and enhance on the training and the learning. So like another concrete example, an endocrinology e-consult first step around thyroid nodules, right? So the PCP's clinical question is submitted ideally through a standardized process that elicits these relevant signals, right? The labs, the trends, the imaging, the symptoms, prior treatments, whatnot. The specialists respond at the level of the patient, of the PCP's clinical question and understanding. The same specialist then meets the PCP where they're at multiple times on the same clinical question. And by confirming management, refining workup, or defining escalation criteria, the PCPs, like, they're going to learn over time. So their questions should evolve and become more layered and more complex. Now that's ideal. And I thought Yulia might giggle at me on this one a little bit, because we know that this is also where you see sometimes learning not happening. And so I'll complain, I see, man, I saw 10 consults for a solitary nodule from the same PCP that went to the same specialist, right? But the power of that is I can see that primary care provider received the same education in the same clinical context. And that's a point where I can highlight to an area medical director, you might want to reach out to this person and ask them, like, where are you still struggling with this clinical content and clinical question? How come this, like, we're not meeting you where you're at in your learning pathway? How do we do better to help you learn and advance your skill set so that you can manage these primary care? Like, it's a little bit about upskilling and expanding your scope of practice as a primary care provider, but really become confident with the knowledge base that surrounds you and the patients that you're caring for. Explicit guardrails, I think, are really important as well. Consistently and clearly calling out what needs to be referred to a specialist in the market. You make it safe, you make it clear, with labeling and triaging what's appropriate for PCP management, what's not appropriate for PC management, and what signals should escalate. And this can be like the endocrinologist saying, we always think that type 1 diabetes should be managed by an endocrinologist, like respecting where we're at today within our medical environment and adhering to those guidance and guardrails. And this includes having QA, QI in both organizations to ensure there's alignment and tracking and reporting around monitoring these safety signals and these guardrails. And finally, built-in learning loops are one of my favorite things. The ability to ask another question and have bidirectional asynchronous communication is super high value. So this not only builds trust, but enables rapid resolution of any communication gaps, right? So in a traditional referral pathway, if I send a referral out and I get a note back from a cardiologist and it doesn't make sense to me, or that's a bad example being a nephrologist and a cardiologist, like if it doesn't make sense, or I disagree, or they didn't answer my question, I don't really have a good way to fix that real time. There's been a huge gap. But within a bidirectional learning loop through eConsults, we teach our primary care, like if you get a consult back and it doesn't meet your educational need or the patient gap, or there's miscommunication, ask a clarifying question, ask that follow-up question, and go back and forth with the specialist in the context of your patient so that you feel supported and not bypassed. So I think what we've learned here is that, at least I have with our organization and being on this journey the past couple of years, is that the digital infrastructure needs to nudge along the care model in the right direction. And when designed correctly, we're going to change behavior. There will be discomfort because change is always uncomfortable, but we can keep down the abrasion level and move forward on this journey towards improved integration. Now, Yuli, I talked for a while about where we're at, and I think you have the opportunity to kind of show some more discrete examples and kind of give our playbook.
I would love to. Thank you, Chris. And I always love your nephrology examples. I always feel like I've learned so much. And if anyone wants to come and crash our Friday afternoon meetings, this is basically the topic of discussion, everything that Chris just mentioned and what you'll hear going forward. So we invite you to join our PCP and specialist collaboration movement. Oh, I think did I just exit the slides? Or do you still see the slides? Oh, thank you. Perfect. I was meaning to advance them. So Chris just shared the 4 different critical capabilities for PCP and specialist collaboration. And I wanted to take a moment to really underscore the first pillar, which is establishing the shared clinical context. This entire process starts with having a good clinical question. And I think this is really key for all of us to think about, because the outputs, which are the specialist recommendations, are really only as good as the inputs, which really is that clinical question that Chris was talking about earlier. So that is where we've really focused our energies over the last year or so that PCPs are asking better, earlier questions that encourage the kind of collaboration that we're trying to facilitate. So in the traditional model, referrals, as we all know, they act as a catch-all. And like Chris mentioned, the EMRs make it super easy to refer out if there's any uncertainty. However, much of the time when PCPs, like me, place referrals, it's because we're looking for some sort of guidance. And oftentimes the cases that we're sending don't necessarily warrant transferring out the care. And what we're looking for is usually one of 4 things. It's help thinking through a decision. It's help approaching a case with clinical uncertainty. It's help in validating the management plan, and if there's anything else we should be thinking about. And it's help determining if an escalation is actually necessary. And so a lot of the guidance for the workup and for the treatment can be provided by specialists to the PCP through the asynchronous model if we ask the questions well. And I think importantly, it's important to note that a good clinical question is useful both for eConsults and for in-person referrals. So it cuts across the entire ecosystem of that specialist bridge, whether it's to the upstream or to the downstream levels of care. So that's why we have been laser focused on helping to facilitate this process. And we've done this in a few different ways. We've really focused in on clinical education efforts and creating curated specialty panels. We've been working on requiring clinical questions before an eConsult or a referral is processed. And we've also been working on removing that default drop-down menu that most of us have in the EMRs that say evaluate and treat, as opposed to having space to include what you're actually looking for. Now, this is definitely an ongoing process for us, but we've seen that when there are better questions, you get much better responses, and patients also get better care. So the next thing I want to note is that in the integrated model, it works particularly well when you focus on the right use cases and have the right guardrails in place, rather than just like deploying a one-size-fits-all model across every single referral that comes through. The goal is to appropriately triage cases that can be managed by the PCP with the specialist guidance versus cases that should be managed directly by the specialist. The collaborative care model that we're talking about, it works particularly well for a few use cases, and that's when PCPs are already managing the majority of conditions, when disease progression is slow, but it can be mitigated, when there's clinical uncertainty, and also when procedures are overutilized or not necessary. So we included a few examples here to really illustrate this. And so the first is with non-procedural specialties. Some of the good use cases are around diabetes, thyroid disease, CKD, Chris's favorite, dermatology, and a bunch of other conditions. And this is, the PCP really has the opportunity to own the longitudinal relationship and the longitudinal care. And the specialists can help guide diagnosis and treatment plans. And the other thing the specialists are particularly focused on is providing tiered recommendations and adjusting how, and providing recommendations for how to adjust care depending on what's going on with the patient. You're also going to see an example below of a 72-year-old lady who has a derm condition. And so this is an opportunity for the specialist to weigh in based on the history and on the photo. And then the PCP has the chance to work with the patient and carry out the plan rather than waiting 3 to 6 months to get an appointment or however long it is in that particular market. So then so that's non-procedural specialties. For procedural specialties, the approach is slightly different, and this is because we focus on conditions that often have unnecessary referrals or ones that have a lot of procedures, again, not all of which are necessary. So an example here is for ENT. Oftentimes, folks send referrals for hearing loss directly to ENT when they should have an audiology assessment first, and then triage appropriately as to what's going on, rather than having to wait, again, the 3 to 6 months to get an appointment for, what might be like normal aging hearing loss, as opposed to a more serious condition. Another example is for GI with colonoscopy. Sometimes it's necessary, and sometimes a specialist can help evaluate the risks versus benefits of doing PrEP in a frail elderly patient when there may be other modalities that are available to do the workup. And so that's another opportunity for that shared decision-making between the PCP and the specialist in service of the patient. Now, these are some good use cases for the collaborative model, but not all conditions are appropriate for the integrated model. And some patients should very much go straight to in-person specialty, and the specialist should own the care directly themselves. And so some examples of that is active cancer treatment. That should go straight to the specialist. ESRD, severe autoimmune disease, and the list goes on for what those conditions are. But I think what's really important to remember here is that it's important to have discrete pathways rather than, again, that one-size-fits-all model that patients, so that patients can really get the care they need, and PCPs and specialists aren't wasting their time on the wrong cases as well. All right, so what does this actually look like in practice? The goal is to support collaboration and extend the PCP scope and the specialist guidance for clinically appropriate care. So to roll this out, we developed an implementation playbook to really guide behavior change and to really integrate the program into the overall CenterWell Conviva care model, rather than just having it be a side project or a nice to have or something that just sort of exists that nobody uses. So we took an operationally deliberative approach here, and we focused on 4 different things: on workflow design, leadership alignment, PCP engagement, and clinical education. And we built it around pretty much like 3 interconnected levers. The first one is the eConsult First initiatives that Chris was mentioning. Again, this is establishing a structural default that normalizes getting early specialty input before ever placing a traditional referral. The second is market leadership engagement, and this is enabling for the initiatives to be driven by the local teams to create a systems-wide shift. And then the final one is PCP training, clinical education, and here building out the clinical trust and the habits to make the model sustainable over time. Again, all of these levers are interconnected and they're iterative, and the goal is to drive integration and to really deliver on outcomes. All right, the moment we've all been waiting for. This is the eConsult First initiatives that we have been referencing. And so we wanted to show you some data and go into a little bit more depth here, because when they are done well, they really do help facilitate the trust between PCPs and specialists. So as Chris mentioned earlier, eConsult First initiatives are not meant to be a restriction on referrals. They are meant to be that structured entry point for PCPs, and it's an opportunity to assess whether the care can be managed by the PCP with the specialist help, or whether the care should go onto an in-person referral and for that transfer of care as well. So we have been working with a variety of different markets on rolling out a variety of different eConsult initiatives across different specialties. So this works in many of the ones that folks choose. So in endo, nephrology, rheum, urology, ENT, and others. And most markets will select the 1, 2, or maybe 3 eConsult initiatives that they want to roll out, and largely based off of ones that have high volumes of referrals, ones that have large access barriers, and also importantly, ones that are impactable conditions. Again, oncology does not belong in an eConsult First initiative versus endo and nephrology are great use cases, which is what we're highlighting here. So starting with endocrinology on the left, the focus here was on diabetes, thyroid, and other metabolic disease. And usually for these cases, and like why the eConsult First works well is because PCPs manage the longitudinal relationship, and the specialist can help guide workup and medication strategies, can support adherence and lifestyle tools, and can help define escalation thresholds as well. So what you're seeing in the data, both for endo and nephrology, is that the trend lines, the green is the line for eConsult volume and on a per provider per month basis, and the blue is the referral, in-person referral volume on a per provider per month basis as well. So taking a look at endocrinology first, the program launched in late January of 2025. By February, there was a rise in eConsults and a drop in referrals, which continued for the next 3 months through April. In May, we did see eConsults drop and referrals rose, and then both continued to decline throughout the summer. We think this is largely due to seasonality, as there's an influx of patients in Q1 who need to be managed. And then there were also some competing priorities as well. We rolled out multiple eConsult First strategies across multiple specialties, and so that may have been a contributing factor too. But I think the important thing to note here is that part of why this initiative worked so well, at least up front, is because it minimized the workflow changes, as Chris was describing earlier. So PCPs placed referrals according to their standard process, and then these referrals would be transferred to an eConsult first, rather than automatically getting scheduled. All right, so then we have nephrology, and I'm delighted that I get to talk nephrology as a PCP when my favorite nephrologist is right here. But this again is an example of the collaborative care model. I think we're kind of living it together, Chris, here. So for nephrology, this was an initiative around CKD3 in another market. Across the Medicare Advantage population and just the general 65 plus, there is a large aging group of patients with high CKD rates. Oftentimes, CKD is treated late, and as Chris already mentioned, after irreversible progression, when we very much could have done something ahead of time. And early nephrology is very important to slow decline and can help with optimizing medications and helping properly monitor labs and function. There have been a ton of studies on this that show that patients have better outcomes when a nephrologist is on board, particularly starting with CKD3, but maybe CKD2 and CKD1 as well, and not waiting until you get to CKD4 or 5. However, the support doesn't have to be in person as long as the nephrologist is guiding the care. So what you'll see here is that the program launched in April and then consistently had increased eConsult use and decreased in-person referrals for these conditions. And the reason that this worked particularly well was, one, because we reduced operational friction by piggybacking again on those existing workflows, and two, because PCPs were seeing the value of the recommendations and thus were more readily embracing the initiative. So I think the moral of the story here is that eConsult first initiatives can be very meaningful for shifting utilization patterns and for clinical outcomes, but specifically when they are embedded into workflows and when they're reinforced across the whole model. All right, now our next engagement strategy is around market engagement. One of the key elements here is making sure that market leaders own the program and build the clinical strategy, again, rather than just viewing it as a side project or something that is a nice to have. Each market has their own nuances and dynamics, and the market leaders are the folks who are setting priorities, they're allocating resources, they're driving the care, they're creating the culture in their own markets. And so they are very much the best people to deploy the model in a way that works for them and for their teams. For us, how this worked is that we prioritize working together with the market presidents and CMOs and their leadership teams so that we're all on the same page as to the purpose of the model and we can best support the implementation. So this involved having at least monthly meetings to review data, to review what's going well, what can we improve, where are the opportunities, and then where are there specific conditions or specialties that could benefit from the collaborative care model. So market leaders would typically block off about 15 minutes during their regular meetings to review together, and then they're the ones who decide what initiatives, such as eConsult First or educational workshops, would be best to drive impact. And part of the result of this is that for PCPs, this helps to drive behavior change because when you have the entire ecosystem and surrounding systems, they're creating easy workflows, consistent feedback, and embedding the program into the model, it's easier to adopt it into your daily practice as well. Which brings me to the PCP. This is very much the most important key stakeholder of the entire integrated model. And so we really focus on PCP engagement and training to foster buy-in from PCPs. And we take a very individualized approach together across all of our teams to demonstrate the value of the PCP-led, specialty-informed, decision-making collaborative model. And this is very much, it's different than practicing in the traditional model, so requires a bit of demonstration here. And so at least up front. And so we work together on initial refresher trainings, and then we really focus on showcasing use cases and helping PCPs go through their own panels and identify opportunities where they could collaborate directly with specialists rather than referring out and introducing some delays. I think for me, my favorite moments, and Chris and I have had some of these together in talking to PCPs, is when you see a PCP have an aha moment and the PCP says, oh, this actually would be helpful for Mrs. Smith and her rheumatoid arthritis. Let me try it. And so that's the gold. And ideally it reinforces itself as they see the benefit for their patients. All right, and finally we have the final pillar, which is PCP education. I think that we've talked a lot about trainings and workflow support and model integration to make the model easy to use. But I think it's that education piece that really builds trust and confidence and reinforces the value of PCP and specialist integration. So we address this in 3 different ways. The first is that we've created curated panels so that PCPs really get to know their specialists and form the relationship and the trust. And that was a lot of what Chris was referencing with the thyroid nodule example, that, by the time you've gone back and forth on the 10th thyroid nodule, then you really trust your specialist and figure out what to do for the next patient, for the 11th patient. So the second thing we do is really highlight the eConsult case studies. And these are real examples from peers that show how specialist guidance has helped others. This is an opportunity to make it concrete, no longer theoretical. And so one of my favorite cases has been an elderly patient with multiple comorbidities who had was going to the ER every other week or so for severe anxiety. She'd come to the clinic, then she would be, a few days later, she'd go to the ED, then she'd go back to the clinic, and it was just this repetitive cycle. So the PCP submitted an eConsult. The patient was on a few meds, hydroxyzine and venlafaxine, and the PCP asked if there was another medication that they could add to that would be helpful, and suggested a few they were thinking about. So this went to one of our psychiatrists who suggested a detailed treatment plan, basically reviewed everything, the whole story, recommended weaning off of hydroxyzine since it wasn't helpful according to everything that she saw, then recommended that you don't need a second drug, you just need to optimize venlafaxine first, and then provided a very detailed plan of how to do that week by week and what to look for and what side effects and what to monitor for. And then also noticed that there was a benzo on board. And so I was like, take off that benzo. This patient is a full risk. So, and then we checked in with the PCP a while later, and the patient had not gone to the hospital for 2 months at that point, which is really amazing. And that really brought it home for her and for the patient and for the various other PCPs that she worked with. So I really enjoyed that example. We have more, so, circle back with us. And then back to the education. The final thing that we do is grand rounds. And this is another layer to, again, help build trust and to develop skills around the clinical narrative, the clinical context, and the collaborative approach to care. And so in these grand rounds, specialists, they provide general education on conditions, they'll discuss specific use cases, and then they'll also reinforce, again, which are the right cases for e-consults and how to ask a good clinical question. And again, this helps build trust, helps broaden the PCP's perspective on what they can manage with the specialist guidance, and helps to really facilitate the collaboration. So I think education on its own, it's not enough to drive things like this, but when you couple education with workflows and culture change in education, that's when you really have a chance to strengthen the process and the integration. Which brings me to the end of our presentation, and the future that we are aiming for is one in which we have an effective and integrated model in which PCPs and specialists collaborate and share decision-making and get expertise to patients earlier. It's a future in which the PCP very much remains at the center of care, and specialists are the extended care team around them who provide support, who help with shared decision-making, and help with how care is delivered. And as we've been discussing, it's a shift in how expertise is applied rather than who owns a patient. And what this looks like across the board is that PCPs are confidently managing a broader range of conditions because they have access to specialists early and consistently. Specialists have their expertise embedded in primary care decision-making. External referrals are high yield and appropriate. And most importantly, patients experience continuity rather than continual handoffs, and they don't have to navigate complex and competing systems. And so this model, the way we've been deploying and designing it, it's meant to drive better access and outcomes for complex populations. And with the partnership between CenterWell, Conviva, and Arista, we've made a lot of great strides already, and we're excited to continue deepening the PCP and specialist integration to really deliver on outcomes for patients. And I see that Tiffany has joined us, so I believe we are ready and excited to answer any questions that folks may have.
Thank you so much, Dr. Jesmer and Dr. Logar, for walking us through that blueprint for integration. It is really powerful to see how moving specialty thinking earlier in the clinical narrative can transform the two islands of primary and specialty care into a single coordinated system. So we've seen the theory, now let's talk about the practice. We have both doctors here to dig into the how of this model, from managing clinical guardrails to using asynchronous consultations to keep the PCPs in the driver's seat. I already received excellent questions about how this actually changes the daily workflow in a busy center. And so let's dive into our Q&A and explore how we can apply this blueprint. Our first question is, do PCPs connect with the same specialist, or is it a random specialist each time?
So it is, and Yulia, you can chime in as well, but the goal, at least in our high volume specialties, is to try to narrow the panel. So the idea of the curated panel is that we are matching, say, a narrower number of specialists to a specific market. So if it is, say, vascular, you probably are going to get the same person every single time. And I thought Yulia was going to out me for reading Dr. Scudder's vascular e-consults for fun because they're so amazing. But in endocrine, it might be one of three. if what is great is if you ask a follow-up question, it will go back to the same specialist. And if the same patient comes back in 2 or 3 months and you want to again tack on and ask an additional question about that patient, Arista does a great job of trying to get that back to the same specialist again. So the idea is that you're able to have this back and forth, conversation asynchronously. I think also then it builds on knowledge and helps to identify gaps. So if you are submitting a very similar question, like using the thyroid nodule one, and we should see growth and we should see increased understanding and improved management by primary care. So it helps because you're using the same language, right? The specialist responding, and we're all, there's 100 nephrologists, we're going to answer the same question 100 different ways. They're all going to be right and focused, but it's like that communication pattern starts to grow and evolve. So you can meet the specialists can meet the PCPs where they're at. The PCP can feel confident that they can ask the special, like you've got to be a little vulnerable to ask specialists, questions about, hey, I don't really understand what you just said. Please clarify that further. Or that's not, I've actually seen some where they've said, that's not really what I meant to ask. This is actually what, like, thank you for the answer. That was helpful, but this is actually kind of where I was going in my brain. So it's a learned skill. And so connecting to the same specialists helps, and it's curated too. Like I think usually 2 to 3 per market per specialty.
Thank you so much for that response. Our next question is, you noted that referrals are often a late transactional bridge. How does moving the specialist thinking to an earlier stage in the disease progression change the actual clinical outcome for the patient?
I can start on this one. I think this is the goal here is to get upstream of, by the time you send a referral at the downstream side, if you have, for example, heart failure and you have a severe exacerbation, or the patient has been having symptoms for a long time, or they've been, not optimized on their medication, you're catching them after they're quite sick, as opposed to catching them upstream where maybe they're just starting to have a little bit of shortness of breath, and maybe you've noticed a little bit of, increased fluid on their legs, and you are doing an early workup, early management, really getting ahead of their care before they're further exacerbated. And so getting upstream, doing both the early management as well as even focusing on prevention. I think a lot of our specialists will also look for opportunities to address. They'll look for other things. If you ask a GI, for example, a question around, constipation or abdominal pain or whatever it is, and they notice that a patient hasn't had a screening colonoscopy in 15 years, they'll note that as well. So they're looking for the preventative care too.
I agree with that completely. And I think even for me, as one of my areas of weakness is dermatology, right? So I would be prone to say, well, let's try this for 2 to 4 weeks and see what happens and come back and see me. And if it doesn't get better, then we'll send you to a dermatologist, right? Versus I'm going to take a picture of this. And I think I'm going to give you this prescription. We'll take a picture. I'm going to ask, we have dermatologists that we can ask questions of using the service with Arista, and I'm going to send them your photo. Go home with this. I will call you in a couple days to let you know what the dermatologist says. So, I can, reconfirm the decision that I made with the patient. I can, or more earlier, adjust course if I've not gone in the right direction with my initial diagnostic or therapeutic intervention. So I think that pick any specialty you want. We could find examples like this where lowering the barrier to asking a question earlier about diagnosis, treatment decisions, optimization or risk, anything really can get you upstream as opposed to human nature. Look, well, let's wait and see, or let's, see what happens. I think anyone here on the call also can provide a million examples of, how the wait and see approach is applied in medicine. And that's kind of also what we want to change.
Thank you both for that answer. Adding on to this, traditional referrals are often like a late bridge after the disease has progressed. Could you talk about the positive impact on a patient's peace of mind when they get specialty thinking applied to their case within days rather than waiting months for an appointment?
I love this question. And this is one of my favorite things about this is there's, as an access to care initiative, we didn't really talk about it this much with this presentation, but I do think this is a very powerful part about an e-consult relationship is access to care. So every market has especially scarcity somewhere. And it changes, it's different, right? It's 9 months to see a nephrologist in Louisiana. It might be 6 months to see a rheumatologist in other areas. And everyone taking care of a panel of patients has transportation barriers or resource barriers, right? Our patients, I have to fly across the country to take my dad to an infectious disease treatment. Like, I'm grateful to be resourced to do that, but that is a lot. And so this exists everywhere. A large percentage of referrals go incomplete because of a transportation, a cost, a resource, a barrier. So e-consults, by being able to ask that question, you could say to the patient, hey, I see that you have a cyst on your kidney. I don't know what to do with this. I'm going to place a referral to the nephrologist. I know the nephrologist, speaking as a nephrologist, is going to deprioritize that referral. And it's going to be 6 to 9 months to see a nephrologist. The patient doesn't have to wait 6 to 9 months worrying that they have a cancer. They can, a nephrologist or urologist, potentially more appropriately, can review the imaging and, hey, that looked like a benign cyst. These are the things I'm going to do. So not only have we avoided a downstream low value referral, but that patient isn't waiting 6 to 9 months to see a nephrologist. This is an example I just heard yesterday from our nephrology team in Broward, right? That how anxious the patient had been waiting to get to this new patient appointment about something that was, very straightforward and could have been resolved quicker. So there's a lot of parts of the system that would benefit in that situation. And most importantly, it's going to be peace of mind for that patient who isn't waiting to hear about the next best step or hear about, receive diagnostic clarity around, do I have rheumatoid arthritis, or do I have an autoimmune disease, or do I have a scary skinitis thing? I think we can get upstream and help patients with access to care issues, including then also helping our homebound patients at the same time.
We're going to take that blueprint and see what happens when the stakes are at their absolute highest. We're moving from a discussion of general clinical models to a partner spotlight on a population that literally cannot wait for answers. Our next session, we are welcoming Dr. Richard Stefanacci, the medical director for Inspira Life. Dr. Stefanacci is going to walk us through the world of PACE, the program of all-inclusive care for the elderly. In the PACE model, primary care as the control center isn't just a catchphrase, it's a financial and clinical reality. As a full risk provider, Inspira Life bears 100% responsibility for every dollar and every service, from transportation and home aids to every single hospitalization and specialty visit. When you're fully at risk for a population with an average of 8 chronic conditions to 10 daily medications, a 26-day wait for specialists isn't just a delay. It's a danger zone that often leads straight into the ED. Dr. Stefanacci is going to share how Inspira Life uses Arista MD e-consults to bypass that 26-day wait, delivering subspecialist guidance to their interdisciplinary team in hours rather than weeks. Please join me in welcoming Dr. Richard Stefanacci for the session, Full Risk Care, Specialty Access, and the Programs Keeping Older Adults at Home.
Thanks, Tiffany. And thanks, everybody. And again, as Tiffany's mentioned throughout, if you have questions, please use the chat and we'll have time at the end. This is definitely not going to be death by PowerPoint. But I also want to chime in on some of the thinking that's occurred so far today, because I've been sitting in on the sessions. But again, we'll talk about a little bit about what Inspira Life, or a PACE program, is and why e-consults play so well into that. And then in addition to that, we'll talk about some unique models that I think would apply, or I know will apply, to any payer provider organization or anybody that's at risk on the financial side. And that's 3 unique programs that we have. One is before 911, and we'll go in more detail into this. One is called Flip, and one is called Rabbit. And really, again, picking up on the theme of the last discussion, we are aggressive in using e-consults first, and I'll show you in a moment how that plays into the payer or payvider PACE type model. We also use it as a prep, where we have a significant delay in getting our our participants. We refer to our patients as participants. And also significantly, as Tiffany pointed out, the timeliness of our consults, which plays really importantly into how we manage our patient population. So jumping into giving you a better understanding of what PACE is. So PACE stands for the Program for All-Inclusive Care for the Elderly. And because of some confusion with that, an acronym used in the East Coast market, we also use LIFE, which stands for Living Independent for Elders. So again, what we are is we're a full risk provider group. So nationally, there's almost 200,000 participants or patients enrolled in the program. It's in 32 states because the states have to approve the program, even though it's federal, because it's a combined Medicare Medicaid program. Our funding comes from both sources of Medicare and Medicaid. And the program's been around since the 1990s. So it's been around for quite some time, starting in San Francisco, initially in the Chinese community in a program called Unlock. So it treats a unique patient population, which Tiffany mentioned. Our patients or participants have to be over the age of 55. Specifically for Inspira Health, the communities that we serve are 3 counties in southern New Jersey. And in most markets, PACE is non-competitive. In California and a few other markets, PACE programs can exist in the same zip code or geography, but in New Jersey, for example, our program is exclusive to these 3 zip codes. Clinically, to be enrolled in the program, your needs have to be those that would warrant 24/7 nursing home care. So again, an older patient population, very frail in requiring nursing home needs. But when you start in the program, you live in the community. And then if you do wind up going to a nursing home, assisted living, or other place, we continue to care for you. And as mentioned before, you need to be Medicaid eligible, and most are duals, having Medicare and Medicaid, and that's where the funding comes from. And once enrolled, participants pay nothing for any of their care, including over-the-counter medications or anything even beyond what Medicare and Medicaid would pay for that the team feels is appropriate. So for example, we pay for window air conditioning or home improvements. Because again, if we could spend those dollars to keep somebody safe in the community versus a nursing home or a hospital, that's a return for us, as well, obviously, as the participant. As Tiffany mentioned, as a result of this criteria, the majority of our participants have a significant number of chronic conditions, a significant number of medications that they're taking or should be taking on a daily basis. And our average age, not surprisingly, is 76 years old. So again, we're fully at risk, so it really aligns well with e-consults, and we're talking about specifically how we're utilizing those. Our financial risk includes transportation. So in addition to the benefit of reducing a consult and paying for the consultant, we have to pay for the transportation costs. We also have to pay for home aides and personal care assistants. So a lot of our participants, because of their frailty, need to go to a specialty visit with an aide. So again, that's another expense for us. Not surprisingly, again, we're responsible for hospitalizations, medications, the specialty visits, and nursing home placement. So improving our utilization of specialists and our overall care not just has an immediate cost reduction of the specialist, but also transportation and the aides, as well as improving care and reducing our use of emergency rooms, hospitalization, and nursing home placement. So it really, overused phrase, but it really aligns well with us and is a really ultimate win-win in using e-consults. So again, the problem in our market, and this is probably true in most of the markets on the call, is despite the fact that we're a integrated health system, even getting to our own specialist takes us a significant amount of time. 26 days is not uncommon in our market. So for a lot of our participants, that delay would result in them winding up in the emergency room. So again, in really thinking about this in 3 big buckets, we utilize that e-consult first discussion around dermatology, endocrinology, and a lot of those cognitive services, and that's worked into our workflow. We also utilize it as a prep. So while we might schedule a neurology consult, for example, and not be able to get that participant in for 4 or 5 weeks, we'll utilize the e-consult as a prep before that face-to-face occurs so that we could optimize what's needed. So when they do see the specialist, everything's available. So it's not, okay, I've seen you, I've done an initial assessment, now I'll see you back in a month. We make that first face-to-face much more efficient through the use of e-consult. And really critical is the timeliness. Getting a consult back within 24 hours feeds into a few of the key programs that we're working on that can probably apply in your market as well. So again, the specialty access kind of reimagined having the Arista MD e-consult service available again for those e-consults first, for those cognitive services as a prep, and the timeliness of the consults and getting those answers back. And we found the same thing that was articulated in the last discussion. As a result of all of this, our primary care providers are utilizing specialists and even their own care much better over time as a result of this interaction with the Arista MD specialty network. So again, the real world impact for us, we've had a significant reduction in our utilization of specialists. And again, this is not just a savings in time, but also a savings financially, not in the consult only, but also the transportation and the aid expenses. And we're just now tracking, because we launched this a little bit under a year ago for our PACE program. We're tracking some of those other outcomes to see how the impact is on our ED utilization, hospitalization, and others. But we have already quantified the direct impact on our use of specialists and the reduction there as a result of that. And again, that has tangible financial impact for our program. Now, again, feel free to use the chat feature for questions, and we'll get to that in a few moments. But I want to spend a few minutes talking about some innovative programs that we've initiated and how Arista MD e-consults fits into that. So 3 particularly, and everything's got to have a catchy name to it. We have the 4911 program, Rabbit, and Flip. And I'll talk about those in detail, and again, about how e-consults plays into that. So the first one is Before 911. So again, as a provider organization that's at financial risk through our PACE capitation that we receive from Medicare and Medicaid, keeping our participants out of the emergency room is critically important, because the vast majority, given their level of frailty, when they wind up in the emergency room, unfortunately get hospitalized. And the average length of stay for hospitalization is about 5 days, costs several $1,000s as a result. And none of our participants comes out of the hospital in better shape than when they went in. So we've launched this Before 911 campaign. It's really focused on 2 major arms. One is to call us beforehand, before your chronic condition has an exacerbation or deterioration to the point that you need 911. And also as a prep, so that if you do need 911, call us, let us know so we could call the emergency room and give them a heads up so that that visit is more efficient and effective. And that plays into our next program, which is Rabbit, which I'll talk about in a moment. But really, the e-consults plays well here in the Before 911 prep. So patient will call us, say they're having a challenge with an exacerbation or near exacerbation of their COPD, a flare. So unlike a non-e-consulting service where it would take us weeks to get them in front of the pulmonologist, we can get a response back within 24 hours to mitigate an exacerbation of that COPD, make adjustments that's appropriate. Same thing with cardiology or nephrology. So again, in thinking about this Before 911, since we're at risk and trying to keep our participants out of the emergency room, educating them, getting them to call us early when they're having a exacerbation or things are deteriorating, we can get that information in the front of a specialist and get a consult back within 24 hours, I can make adjustments to their treatment plan that could oftentimes mitigate the need for an emergency room visit. So again, seeing how that e-consult, because of the timeliness and the effectiveness of those consults, can play into a before 911 initiative, again, for organizations that are fully at risk or really focused on keeping frail elderly individuals out of the emergency room. You could see how e-consults really serves well with the before 911 program. And again, the before 911 feeds into what we affectionately call RABBIT. So RABBIT stands for Rapid Assessment and Initial Treatment. So again, one of the two components of that before 911 is patients had a deterioration. They missed the opportunity to call us early. They need to go to the emergency room. They've called 911. They call us so that we can give a heads up to the emergency room. And the goal there is that our emergency room knows that this is a RABBIT patient. They'll make a rapid assessment. So for example, a patient has a early pneumonia. We'll make that initial assessment, recognize the early community-acquired pneumonia, start the initial antibiotics. If it's severe enough that they need IV antibiotics, put in a PICC line, first dose of antibiotics, send the patient back to us, and we continue to provide that follow-up rather than a hospitalization. Now, the e-consult part comes into play in that patient coming back to us in the community, the ED feels much more comfortable knowing that we could have that patient evaluated and worked with our primary care team with specialists within 24 hours. So again, rather than the ED being concerned, gee whiz, I need to admit this patient because they need to be followed by a specialist, and we're not going to have that ability in the community setting. Having the ability through Arista MD and getting a consult back within 24 hours allows us for patients that need pulmonologists, cardiologists, nephrologists, others to work with our primary care team, get that information to the Arista MD team, get a consult back, and modify or adjust any treatment plans that we need. So again, provides the needed level of comfort with the emergency room so they're not inappropriately admitting a patient that could be cared for through our system in the outpatient setting. So again, before 911, getting patients before that deterioration through a timely consult, RABBIT, getting the ED comfortable and sending a patient back to us so that we could follow up on that treatment that's needed, make modifications rather than having that patient in the emergency room. So two programs to kind of think about and how they might fit and how the benefit of using e-consults through Arista MD kind of works for that. Another one of kind of the innovative programs that we're playing with is FLIP. So we used to have this falls committee, and our falls team would get increasingly frustrated that they couldn't do anything to prevent falls, despite all of their efforts. So, and really, again, that's not the key. It's not necessarily preventing a fall, but preventing an injury from a fall. So we changed that around or flipped it to what we refer to as FLIP now. So that stands for Falls Limiting Injuries Program. So the focus is really on what can we do to optimize that if and when a patient has a fall, that they're not going to have a significant injury from that, a bleed, a fracture. So one of the things we do here, again, is the timeliness of that consult and getting our consultants to appreciate that's what the objective is of the program. So we could consult, again, cardiology on patients that are having syncopal episodes to see what we can do to reduce that, especially if they're on anticoagulants and the potential for a bleed. Neurology, patients with gait disturbance and sending a video, having a neurology consult in a timely managed period, before somebody has a fall and a fracture. And again, obviously orthopedics. So again, FLIP, fitting those consults in both from a timeliness standpoint and getting the consultant really to appreciate what the objective is. So in our consults that we're sending, our PCPs know specifically in the ask part, and we send our consults in a unique way so that the specialist that's reviewing it knows how to feed us back the information so it's really effective and efficient for us. And the way that we do that is through an AI structured SBAR. So SBAR, if you're not familiar with, stands for Situation, Background, Assessment, and Request. So we provide our specialists with a setup on what the exact situation is that we're dealing with, what the background of that situation is, diagnosis, medications the patient's on, recent medications, what our assessment has been, our physical assessment of the patient, any additional information in that assessment section, and then specifically in the request, what we're asking for. And we frame it around the fact that these are PACE participants. We provide a little description of what PACE is, what the goals of care are for our participant, whether it's part of the FLIP program, RABIT, or before 911, what that means for the specialist when they're coming back to us with recommendations. And we're able to do that through an AI structure where we pull information from our EHR. We provide structured prompts to our PCPs, and it generates a specific SBAR that we feed back into the eConsult request. And I shouldn't just say eConsult. We're doing this for our real-time specialist consults as well, so that we get better face-to-face consults coming back to us. And we submit that information directly to our Arista MD specialist and have gotten back phenomenal, very focused, especially consults information back to us as a result of that. So again, a few programs that we're really kind of looking at regarding before 911, RABIT, and the FLIP program. And what we've seen, again, as a result of all of this, is really some significant outcomes. And it really focuses on that timeliness, that we could get the consults back, in less than 24 hours oftentimes. That, again, it reduces significant cost to us as opposed to a face-to-face. We don't have the consult, the specialist face-to-face consult cost. We don't have the transportation cost, and we don't have the aid expenses. And the other expense there is that, 90% of the time, the consultants are asking for additional studies, sometimes of which are unnecessary, and really because they don't have a full scope in the ask that we want them to focus on. And on our participants, again, the average age is, 76, significant chronic conditions. A trip to the specialist is not an easy endeavor. So the burden to the participant and not having to go to a face-to-face appointment is significant. So you can see across the top there, some real significant benefits. As been mentioned before, we've seen directly that the PCP education and clinical growth as a result of the interaction, structuring the ask very specifically, because oftentimes, historically, when they being the PCPs, patients out to specialists, they provide very little information to the specialist, and the consults that we get back are all over the map. You're forced to do that with an e-consult, obviously. You have to provide exactly what the information is that you're providing and what the questions are that you want answered. And that's translated into not only better face-to-face specialists, but their own care in getting that feedback, thinking in a different way through this SBAR model and how they care for patients. Again, middle there, that SBAR, the situation background assessment and request or recommendations really gets our PCPs focused on what's important and getting the best information back from our specialist. And then again, as I mentioned, that e-consults is a pre-visit. So even when we do need a face-to-face, given the delay that often occurs, getting our PCPs to utilize e-consults as a pre-visit so that face-to-face is going to be more efficient and effective is critically important. So again, feel free to use the consult or the chats rather, and we'll open it up in a moment for questions. But again, in summary, there's a real opportunity here to utilize e-consults, not just in these kind of innovative programs, whether it's before 911, RABIT, or FLIP, but again, e-consults first, dermatology, endocrinology as those cognitive consultations as a prep, for that delay in getting a face-to-face consult to make that more efficient and effective, and for timely consults. Again, the foundation of a lot of what we do is needing to get that done, quickly so that problems don't get worse and patients don't wind up in the ED and a hospitalization. They come out in worse than they went in the first place because of that delay inappropriate care.
In our last presentation, you guys were able to see Dr. Stefanacci. It is truly powerful to see the PACE model in action, like I mentioned. He was able to show us that when primary care acts as a true control center, taking on 100% of the clinical and financial risk, we can definitely move mountains for our most frail seniors. Programs like Before 911 and Rabbit are the perfect examples of how immediate specialist access isn't just a nice to have, it's a literal lifeline that prevents functional decline and keeps participants safe in their own homes. Closing that 26-day specialist wake gap down to under 24 hours is how we successfully refuse to accept the danger zone for our patients. Dr. Stefanacci's work at Inspira Life demonstrates what happens when we align incentives to keep people out of the hospital. Now we are going to pivot to another area of medicine where the conveyor belt to high cost, high risk interventions is often working against the patient. We talked about primary care for the elderly. Now we're going to talk about a specialty that affects half of all Americans every single year, musculoskeletal or MSK care. Our next speaker is a complex spine neurosurgeon who reached a turning point in his career at Geisinger Medical Center. He realized that the system was perfectly designed to funnel patients towards his operating room, even when surgery wasn't the answer. He did something radical. He scrubbed out of his last surgery to build the system that he wished existed, which is very impressive. One that prioritizes real-life medical diagnosis and integrated care teams to interrupt the surgical cascade before it starts. Please join me in welcoming Dr. Ryan Grant, founder of Vori Health, for his incredible candid session, Confessions of a Spine Surgeon, Why We're Building a System to Keep You Out of the OR.
Hello, can everybody hear me?
Yes, we can hear you perfect.
Well, thanks for having me, and feel free to interrupt. We can take questions as we go along, but thank you for the warm introduction. Call me Ryan. I used to practice neurosurgery at Yale, and then also Geisinger, which is located in middle of Pennsylvania. Was recruited there to be their complex spine neurosurgeon, scoliosis, spine tumors, some brain tumors, brain trauma, and to also participate in their Walmart, Lowe's, McKesson, self-insured Centers of Excellence program on the employer side. But there are lots of things that are interesting. So before we dive in, a little bit about me, some of the pedigree stuff. Been recognized for value-based care thinking, et cetera, et cetera. I'll let you guys read that on your own, but let's dive into sort of why we're here. So the statistics across the United States and the world are not very flattering. Depending on who you want to read, Harvard Business Review 2019, The Lancet, and 2020 or 2021, or any of the medical journals, or those who have access to open evidence or up to date, you can go read about this. But average U.S. hospitals estimated to do about 50% inappropriate spine surgery. Some studies say 80%, some say 30%, some say 40%. Not a little bit, but a lot. Unnecessary shoulder surgeries, about 50%, unnecessary knee, 30 to 40%. The papers from the Lancet during COVID are pretty damning. In essence, they audited the countries across the world that they have data on, and the average person with low back pain gets the wrong care. So said another way, the standard of care currently in the United States for low back pain is to get the wrong care at large. A more recent audit last year of primary care providers across the United States, majority did not understand or know the evidence. Similarly, on the surgeon side, it's not very flattering either. Last thing I'll say is nobody's trying to be malicious, though, at large. People are trying to do the right thing. We have multiple reasons of how we got here. You could spend a whole semester. But I was taught to operate on inappropriate people. I was pressured at every hospital I've worked on to produce more unnecessary surgery to feed a bottom line. And so, but these are people's loved ones. People die from surgery. People get infected. People go paralyzed. People come out worse sometimes. And while the risks might be low, if you have a complication in surgery, it can be significantly life-altering to the individual who has that complication. So really the philosophy being surgery is a last resort, and making sure that you use it responsibly, just like alcohol. So built a few companies before this as well, but this is some of the statistics in terms of just what's not flattering that I sort of already went over. There's lots of evidence out there. One of the number one predictors of a spine, knee, hip surgery in the United States is an image. The public does not well know that if you're over 30, the chance we find arthritis in every joint is very high. If you're over 50, the chance we find arthritis in all of your joints, including your spine, is about 100%. It's not well understood by the public, including also physicians, that if you have wrinkles on your face and gray hair, you also have arthritis in every joint. I think it's a bit problematic that we call it degenerative spine disease. We don't call gray hair a disease. We don't call wrinkles a disease. In essence, degenerative spine disease runs in the human race. And so making sure that we're really paying attention to people and not pictures. But we have certainly become obsessed with making pictures look better as surgical indications across the world. And we spend a lot of money on it. So what do you see? Lots of crazy stuff out there. I won't name the brand name health plan, where 40% of their patients have not done any physical therapy or conservative care prior to getting to the operating room within the last 12 months. Another brand name health plan, 70% of their members make it through doing no conservative care and then make it to the operating room. So lots of different types of issues of why this happens, but in essence, you don't see evidence-based medicine being practiced very often in this sector across the country. Some places do it quite well, but they're rare. Next thing I'll say as a surgeon, I have no formal training in non-operative care. I was always asked to triage and take care of these patients, but as a spine surgeon, I'm not trained in non-operative care. I'm not trained in conservative care. Find me a physician in the United States who can actually articulate how what they're supposed to write on the prescription pad for physical therapy. Most physicians, NPs, and PAs have been taught to write eval and treat because they actually don't know what to write to the physical therapist. So traditionally, if you have back pain, you go to the emergency room with your primary care provider. High chance you're going to image. And the evidence says you're not supposed to get an image in the first 8 to 12 weeks unless you have a neurological deficit, going paralyzed, or if we have a concern for cancer. But as surgeons also, as the first specialty provider, won't see patients without an image. So we have actually taught our primary care providers to order images inappropriately. Then on these images, we will almost always find something. If you're over 30 or 50, if you're in the Medicare population, we're always finding something. And then that becomes a self-fulfilling prophecy, like the Scarlet Letter. Oh my God, we found something. We need to do something about it. A lot of surgical referrals are based on the image alone and not necessarily the patient's exam or the patient's symptoms. It's rare that somebody actually talks to a person about would they even consider surgery, would they want surgery. We're very much addicted to imaging. And then we also then use absolutes. We tell people you need surgery. When really these are quality of life operations at large. Back, neck, hip, knee, shoulder surgery. No one's dying if they don't get back surgery. Now, if you have red flags where you're going paralyzed, you have an infection, you have cancer, sure, those are a different category. But let's just take someone who has full movement of their legs, no numbness, it's just pain, not to downplay how much pain can affect your quality of life. But a lot of these cases, in my opinion, belong in the facelift category. And what I mean by that is nobody needs a facelift. That is a quality of life operation that is very personal. And every individual have a different answer. If you do not like the wrinkles on your face as you age, you can escalate to evidence-based Botox injections and fillers. And if you still are unsatisfied with the wrinkles on your face as you age, You can go and get an evidence-based centers of excellence plastic surgeon to give you a mini facelift, a full facelift, even optimized for a site of service at an ambulatory surgical center. That is a very personal decision to undergo a facelift. Some people say yes, some people would say no. Now, the question would be, why don't we treat musculoskeletal cases the same? Bone on bone is not a surgical indication on its own. It could be. It is much of a surgical indication as deep wrinkles on the face is for a facelift. You need more information. Someone who has bone on bone knee, who has mild pain, and wants to walk around Target with her grandkids as her end use case is not the same person who's 65, same age, and wants to keep running triathlons. And if doesn't get a knee replacement, will have to give up the triathlons. And so really getting deep on what are we solving for and helping pull the patient can move the needle a lot, quite a bit. And again, why spend all this time on these types of topics? Because surgical has risks and people die. And so making sure that we're absolutely certain that this meets the patient's goals and is truly indicated from their point of view versus forcing people down the surgical arm versus them understanding that it's usually an option. Otherwise, everybody with wrinkles who are over 60, we should just sign everybody up for a facelift after this talk. So on the high value care side, it's about, are we using the right physicians? Are we only using imaging when it's clinically appropriate? Are we teaching people? Are we bringing in a biopsychosocial model? And then the bottom one, number 5, are we really talking to the patient about what they want? That rarely happens across the United States, not just in musculoskeletal care, but in almost every specialty vertical. It's rare that somebody actually talks to the patient about what they would want versus the medical community pushing something on somebody through traditional paternalism. And that's no fault of the clinicians. That's just how the clinicians are traditionally trained. So I would argue that reframe that utilization isn't the problem. Sure, that's what it is. But it's how does the utilization become too high? It's bad decisions. How many people get an MRI before a clinical assessment? Go to Open Evidence if you have access. Good Friday evening research. How many people have an image that is red herring, no relation to their symptoms, people don't correlate it, and immediately sent to referral to surgery? How many people are on opiates before surgery? In some communities, 24%. And like I said, surgery is too often decided by imaging, not an examination. And so using the right physician or a physician-led team, sort of an integrated practice unit is, most of these are clinical diagnoses, history, physical, can make majority of the diagnoses without an image, and then the image is used to confirm a diagnosis. It's rare that I find people practice that way. Then what are we using the image for? Are we looking for cancer? Are we looking for why someone's going paralyzed? Are we looking for an infection? Do they have a trauma? We're looking for a broken bone. We're not looking for any of those, what's called red flags. Then we're getting an image to plan a procedure. And if the patient's 100% against the procedure, does the image that you are ordering going to change the plan of care? Or is it just going to be a picture we put up on the refrigerator that we all look together? And then helping think through our primary care providers and specialists talking to patients in ways that actually move the needle. Often I find that folks scare the shit out of patients. You have a spine that's falling apart. Oh my God, it looks terrible. And the amount of patients I've personally seen who had some other provider said one sentence, just one sentence, that altered that person's life forever is too many. I've had patients where they literally pulled back all their activity, trying to be all tight when they walk because they're terrified that their spine will fall apart because of one sentence somebody said to them that they didn't quite understand. So the traditional medical system is very, very good at inducing fear into people. And one of the number one predictors of conversion to chronic pain is fear. So we do a really good job in traditional care of inducing chronic disability. And there's tons of medical papers on that. And just looking at some questions I'll take a question from the chat right now. Have you ever seen a patient burn an MRI report into their brain after reading terms like bulging disc or degenerative changes? Absolutely. There's actually tons of medical literature on this. Also, in this plays off of some things I was just saying. Is if you describe to a patient they have bone spurs, degenerative changes, bulging discs, they have no idea what that means, but it sounds pretty scary. And you follow those patients along, and what ends up happening to them. Now you say that same type of MRI, but you describe it, hey, you have run-of-the-mill arthritis like everybody else your age. The first cohort who was told they have bulging discs and bone spurs, the chance they can convert to chronic pain is like 2 to 4x higher than the other cohort. Because people don't have a good mental model of what this means. People know what a tree looks like, but people have no idea, is bone spurs bad? Is disc bulges bad? Wherever you live today, you can walk around the foundation of your apartment, your house, your condo. You're going to find micro cracks in the foundation. Do you have to re-level the whole house? Probably not. Wherever you live, wherever you park your car, there's cracks in the sidewalk and the driveway. Do you have to rip the whole driveway up? Probably not. But that's what people jump to in terms of what they're seeing here. And so how you speak to patients, words matter. And we are very good across the medical sector of scaring people and inducing fear, which has been proven over and over again to greatly increase your probability of converting to chronic pain or chronic disease because someone scared you. They didn't mean to scare you, but they did. Now, here's another confession. Confession is, like, this was what I started with. We're using the wrong specialists. Let's take the cardiology sector. Cardiothoracic surgeons are not cardiologists. It's rare that I'll find a cardiothoracic surgeon who actually knows any cardiology. And cardiologists, the non-operative colleague, are not surgeons. Urologic surgeon is not a nephrologist. But what's fascinating in the orthopedic and spine world, we don't use the non-operative colleague in the physician realm. We jump right to an orthopedic surgeon and we jump right to a spine surgeon. It's like asking the cardiothoracic surgeons to do cardiology and then wondering why there's more procedures. I think the country at large has lost track of what orthopedics means. They're like, ortho, I'm going to go to ortho or neuro versus, oh, it's orthopedic surgery. If you're in a surgeon's office, they're thinking about, should I operate on you or should I not operate on you? And if you put the most conservative orthopedic surgeon or spine surgeon, there's tons of medical literature on this as well, against their non-operative colleague, which is called physiatry, physical medicine rehabilitation, PM&R is their other name, they will still recommend surgery 2 to 3 times more often than their non-operative colleague. Now, I won't name which hospitals have actually put the PM&R physician in front of the surgeon through a care pathway. And it drove surgery down because you're practicing evidence-based medicine. 2 systems on the East Coast, brand names, one's in Manhattan, one's a little further north, quietly dissolved their musculoskeletal centers that had PM&R in front of the surgeon because it was driving down surgery too much and hurting the bottom line. Now, this is a classic innovator's dilemma that the average US health system lives off of inappropriate surgery and unnecessary surgery to stay solvent. And you see that during COVID. Turn off elective surgery, which is ortho, spine, some cardiology, fill the hospital to 150% capacity, and they all have negative margins at the end of the day. So at large, US hospitals are not currently structured to even break even practicing medicine, just medicine, no procedures. Even if you fill the hospital to 150% with Blue Cross Blue Shield PPO paying patients. So COVID shows you. Average hospital makes 48%, so about half of revenue, according to the American Hospital Association, from elective surgery, which is spine, ortho, and cards. This is the lifeblood of the current hospital systems. So unless they restructure, they're not going to fix this because it causes literally an innovator's dilemma of insolvency and existential crisis of can the hospital actually stay open if you drive surgery down to appropriate levels. So those who are familiar or not familiar, physiatry, PM&R, These are the non-operative musculoskeletal experts. If you actually Google the American Academy of Physical Medicine later today, or you will find in their mission statement that they view themselves as the first line specialty provider for musculoskeletal non-operative care. They view themselves as the analog to cardiology, what a cardiologist is to a cardiothoracic surgeon. They view themselves as what a nephrologist is to a urological surgeon. They believe they also should be in front of the surgeons. But as I just mentioned, a system can't really do that at large the way they're currently structured because of the innovator's dilemma. So you usually will find these folks put after the surgical consult for all the people the surgeon doesn't want to operate on. Reversing that drives surgery down too much to appropriate levels and risks the health system going insolvent, which is the classic innovator's dilemma. Next thing, MRI doesn't see pain, it sees tissue. I think a lot of people who have forgotten about correlation causation and jump to like, oh my God, you have a disc, that's the cause of your pain. How do you know that? It could be. And so imaging often isn't diagnostic. The original studies for low back pain, no ridiculous symptoms, meaning no pain down the leg, just I have back pain, got an x-ray or MRI. What's the chance that the MRI explains my pain? It's like 15%. It's terrible, terrible correlation. But that's not how we talk to people about it. We use it like this Messiah gospel of 10 commandments of like, oh my God, your MRI shows bone spurs and that's the cause of your pain. And we speak about it that way when that goes against everything we know. So for most musculoskeletal orthopedic complaints, imaging doesn't often change the diagnosis. It can be confirmatory for some things, but as I mentioned, it's great for looking for cancer if you're worried, why someone's going paralyzed, looking for a fracture, looking for infection, or planning an operation. Helping the public and primary care providers and the medical community understand what normal is. Degenerative changes is wrinkles, gray hair. We can make gray hair sound terrible. Complete loss of coloring, or we'll do wrinkles, deep crevices around the eye, no more elastin, degenerative changes, skin's flaking off. Like you could write a radiology report on describing wrinkles and make it sound like your face is melting. And that's sort of what we do on the MRI side. And then you give that to a patient. They don't know what any of it means, and they're terrified. And so getting people to practice appropriately, or the other analogy would be invite a contractor to your house today, have him or her write a report about your kitchen, like what a radiologist will do, and they're going to describe every single imperfection they find. Counter scratch, the caulking's off, the drawer's off 2 degrees, there's some scratches in the floor, and they're going to build a report of every little imperfection. And it's going to sound like your kitchen's terrible. Sort of what a radiologist does, but I think people forget that. And this goes to the question in the chat. On the right one, words really do matter. This has been studied quite a bit. Once a patient reads bulging disc on a report, it does burn into their brain. It fuels the field cycle. And one of the number one causes of conversion to chronic pain is fear. So 3 things that people are told every day that evidence says is wrong. You need an MRI, usually false. As I said, it's your arthritis. Maybe, maybe not. We speak too much in absolutes. And then we tell people you need surgery. But actually, the evidence will say almost never. So trying to get that to be removed from the lexicon of just elective surgery, we don't tell people you need a facelift. We should stop telling people you need a knee replacement unless it's absolutely 100% required, which it rarely is. So there's tons of studies, just to hit this point home again. There is no association between lumbar MRI changes and pain, function, depression, or anxiety. There is also no correlation to the amount of arthritis you have and the amount of pain you have. They've never correlated. Severe arthritis doesn't mean severe pain. Minimal arthritis doesn't mean minimal pain. You can fill an auditorium of people who are crying on the floor with minimal changes or what looks like relatively normal MRIs. You can also fill an auditorium with people with severe arthritis who play golf every day and pop a Motrin in the morning are fine. They've never correlated. They never will, but that's not understood well by the public. There it is there. And as I said before, each of you on this call will have a little bit more gray hair, a little bit more wrinkles, and a little bit more arthritis next year, and then the year after, and the year after that. So human beings, as we age, accumulate gray hair, wrinkles, and arthritis. All of our discs collapse over time as we age. That's why our grandparents got shorter. What George Burns, I think, lost 8 inches. And so getting people to understand what normal is makes it a lot less scary. And giving people choice makes it a lot less scary about what can you really do. And then really hitting this home, surgery is almost never a hard requirement. It's really a quality of life procedure. It requires a conversation with the patient about what are they trying to achieve, what are their goals, and then helping people understand their risk tolerance, because some people get hurt in surgery. And so walking people through doors of, you have surgery, you're all better. Great, that's the easy door. Walking people through, if you have surgery, you're better, but you have a complication, you get an infection that requires a second surgery. How upset are you that you had surgery? Some people be like, I'm glad I did it. Some people like, I would hate that. Well, next door, you have surgery. You're not better, but you're not worse. How upset are you that you had surgery? Last door, you had surgery, it's rare. You're worse. Pain's worse. Maybe you're partially paralyzed. How upset are you? Do you regret it? And some people will say, no, it was worth the chance. I don't like the complication, but I'm still glad I tried. Some patients will say that's a never event for me. Well, if it's truly a never event for that patient and they don't have any of those red flags I mentioned, they shouldn't have surgery because it's against their own risk tolerance. And so helping people understand where they are in their own mind is really patient-centered care. This is fascinating science that chronic pain is almost never a tissue issue. It was a tissue issue at one point, but it always has a nervous system problem. This does not mean they're crazy. This does not mean they're a mental health issue. We've all had this phenomenon. Now that summer's approaching, put a baseball cap on, wear it for a few hours, take it off. It still feels like it's there. Put your sunglasses on the top of your head at the beach for a few hours while you're reading, take them off. It still feels like they're on the top of your head. You're on a boat that's rocking for a few hours, you get off and you still feel like you're rocking. So the brain nervous system quickly sensitizes to a stimulus. That's what that is. Now, if somebody has back pain, shoulder pain, or pain that quickly, continuously stabs them, like that hat or sunglass analogy, your brain will lower the threshold of what's required to fire. Now you add in somebody who's terrified. Oh my God, the pain means I'm going to be in a wheelchair. Oh my God, I'm dying. They can more easily trigger that circuit. And so people can have pain, fear, they avoid their activity, they tend to put on weight, they get deconditioned, that makes it worse, they sensitize to it, and they end up in this vicious cycle of very easily being able to fire a pain signal, even if there's no longer a stimulus. This is why physical therapy alone tends to very much struggle in the chronic pain patient who has a musculoskeletal issue, because nobody's dealing with the overactive nervous system. And when you think about holistic care biopsychosocial is working with somebody to think through their maladaptive thoughts and help them think differently about their environment. And the analogy would be, how does actually mental health, how does actually working with a psychiatrist, a psychologist, a social worker actually help depression? Like what's happening? Somebody trained in structured language is helping somebody think about their thoughts differently to rewire the brain. Therapy is a rewiring exercise. So is learning. And if you do not do this in any of the specialty verticals, whether it's GI, musculoskeletal, oncology, etc., how people perceive and how they think about their experience is very much predicts how they will do, how much pain they will have. And there's fascinating studies that sometimes if you just remove people's fear, all their pain went away. And it sounds crazy at first, but all of us have experienced that. Stage fright. Literally, the thought of getting up on stage in front of people can make people want to vomit. palms get all sweaty. They feel like they might want to pass out. Nervous system, very powerful. And so really thinking about this, and that's sort of how sometimes the magic of the holistic models work. And somebody has very pain catastrophizing thoughts sometimes will actually do better to work first with a pain psychologist, in essence, a therapist specializing in how to think about pain and get them into a better activated state before you put them through a physical therapy or physical medicine program on its own. Sometimes you'll do it in conjunction. There's actually randomized controlled trials about pain, what's called pain reprocessing theory, what I just described, that these are people who were traditionally, this was published in JAMA just a few years ago, who traditionally would have been like, we have no idea what to do with you. Good luck. That if you actually work with people, 66 are pain-free or nearly pain-free at 1 year versus only 20% normally. And then you have cognitive functional therapy, similarly, that this was just published in the Lancet just in 2023, that these holistic biopsychosocial models are very powerful. It's rare to find them in any of our great hospitals and systems in the United States, but they work. I was never trained in any of this stuff, had never heard about any of this stuff in any of my own training as a surgeon. So with all of this, the message was we want to do something different. So I called the previous chair of orthopedics at the Mayo Clinic. We got to do something, because she thought similarly, yeah, we need to do something different. Like, how do we make us surgeons obsolete? So the goal wasn't MSK management. It was, how do we stop the cascade? Like, if you see a surgeon first, the chance you have surgery is way higher. How do you get people from not getting an inappropriate image in the community? Because if they get an inappropriate MRI, the chance they end up in the operating room is way higher. So how do you intercept the imaging order? How do you intercept the surgical referral? How do you intercept the cost spiral? You do these things through a whole person physician-led MSK care team, which is why I shut my practice down, to actually push us surgeons downstream, use those physical medicine non-operative physicians, the cardiology equivalent, non-operative person who's designed to try to get you better, who then works together with a physical therapist and a dietitian and behavioral health coaches, that holistic model, pain reprocessing theory when you need it, cognitive functional therapy when you need it, cognitive behavioral therapy when you need it, traditional mental health when you need it. Dietitians there, 30 to 40% of musculoskeletal issues have a weight component. To be blunt, find me somebody who's 200 pounds overweight, whose back and knees don't hurt. And so if your joints are overloaded, they're going to hurt. And so helping people get better. Also, sometimes people will have pain from an inflammatory response. So for example, I can think of a recent patient who came to us, both knees, both hips, and the back hurt. That many joints usually means there's something more systemic going on. Gluten intolerance. They didn't have celiac disease, but when they removed gluten from their diet, all their pain went away. So they had an inflammatory allergic response, however you want to describe it, but removing gluten from their diet, all their pain went away. And so really thinking through what's really the pain generator, how does this really work, how do we actually help these people? And so we've seen a rise of virtual physical therapy solutions out there that have no physician in loop. PT is certainly required. It's necessary, but insufficient. And so when we stood up on the Vori side, it was designed to be physician-led. Some people can be PT only. But if you're going to also get those 40% of people who are traditionally abandoned by the traditional system, who need pain reprocessing theory and cognitive behavioral therapy and have tons of comorbidities, they're going to need a whole care team wrapped around them. And being able to do that cognitive functional therapy as well. That physical therapy alone won't do. People who have brand new pain, physical therapy on its own can work great. Chronic pain tends to need a multidisciplinary care team to get better. Skip over this for the sake of time. This is the Peterson Health Institute report about some of the different digital players. Vori is the only medical practice that has a physician care team. And these are some results. This is about a cohort of about 800 people. Surgical referral rates, 0.2%. So on the Vori side, we reduced surgery about 80% up to 90%. The goal is not to make surgery completely go away. Surgery can do wonderful things for people, but to remove the inappropriate surgeries and also to get people better if you can without surgery. I'm not anti-surgery. I'm a surgeon, just anti-inappropriate surgery, particularly given how many people can get hurt from surgery. It needs to be used as a last resort. And we see that our surgical rate's very low. We also have a very low imaging rate because what are you using the image for? Are you looking for a neurological deficit, infection, cancer, fracture, planning an operation? Otherwise, it starts to become hard to think about what are we really using the image for. And I find this fascinating. Some of the things that make me proud is 40% of the patients on the Vorich side have already failed traditional care. Very skeptical. They're like, I've already done physical therapy. I already did this, failed physical therapy and injections, and we'll still get majority of them better by integrating a holistic care team, being cognizant of how we talk to people. Words are powerful. Integrating pain reprocessing theory, cognitive behavioral therapy, cognitive functional therapy. You can get most of these people better. And as you saw in that randomized trial that was just published in JAMA just a few years ago, from cognitive functional therapy alone and just pain reprocessing theory, they got 66% of those people better. And if you integrate that with more modalities and an integrated care team, you can get even better than that. And where traditionally these were people who were like when I was at Yale or Geisinger and some of the other health systems, no idea what to do with them. And so had all of these outcomes validated by a bunch of different groups. That's just most to say that they can work. Here's another Medicare Advantage plan. You can get the surgical referral rate really low. So case study after case study of practicing differently, using the evidence, integrating a functional care team, using the right providers. And something that's a little bit different also is wanting to make sure it was real care teams. And what I mean by that is I usually find care teams that are in the medical world tend to be more like marketing, where nobody talks to each other. And the analogy would be like if you have an accountant and an attorney and a landscaper, what's the chance that your landscaper, attorney, and accountant talk to each other, even though they're on your personal team? Zero. The chance a physician and a physical therapist talk to each other in the real world is about zero. They refer to each other. They probably don't read each other's notes. They might, but we wanted to break all that down. So for our complex patients, the physician and the physical therapist see the patient together. They do the history together and they do the exam together. And the physician is able to render a medical diagnosis. The physical therapist is able to render a functional diagnosis, make a personalized care plan. If the biopsychosocial model, cognitive behavioral therapy, pain reprocessing, if they need to, other providers will be pulled in as well. People who are simpler can be PT only or physician only or NP only, but rethinking about how you actually practice medicine, who's in the room, who's seeing patients together, how are you talking to patients, what's the language that you're using, how are you making actually this be patient-centric, how are you integrating shared decision-making, and then are you practicing appropriately in terms of appropriate use of imaging, injections, et cetera, et cetera. And through all this, this wasn't a plan. We don't write opiates, but we find our patients who are on opiates, 42% of them get off of them. And so we've seen many people who were told they need surgery and you can get them better. Again, the secret sauce is not virtual versus in-person or hybrid care. It's using the right providers at the right time, practicing in a different way, which includes understanding fear reprocessing, fear exposure therapy, things that are not traditionally taught, and integrating all of these modalities and operationalizing that. We also take care of GLP-1s, mixed evidence in terms of does it help fusions, does it not help fusions? If you have rapid weight loss, you can have muscle wasting. It's like sort of like fasting or starving yourself. So there's also there is bridging the nutritional surveillance. And so integrating this. Sometimes a GLP-1 is the right answer to somebody for their back pain. If they're 600 pounds and nothing else has worked, GLP-1 will still be less expensive than a bariatric surgery if they can also bring in behavioral change at the same time. But not to get GLP-1s like we see some other companies do, where it's given out like water. We're pretty limited in how much we often do this. It's a last resort. For those who want GLP-1s for anything, there are other businesses for that. So we sell to employers, health plans, brokers. We work with at-risk primary care providers who are in essence function like providers. But when you do this well, like you can get members better who traditionally can't get better. You can lower the ER visits. You can increase member satisfaction. You can help people get off of opiates. And you're doing things that don't require needles and as much surgery. So the health plan saves money. The members' experience gets better. People are actually getting back out to the lives they want. And so it's, I would love to see more people copy this. As I said, I don't expect the health systems to do so because of the innovator's dilemma. They rely on surgery to stay afloat. And so there is no incentive to drive surgery down to evidence-based appropriate levels, because that will usually make a traditional health system in the United States literally go bankrupt unless they restructure. And the last time I've seen a multi-billion-dollar conglomerate, particularly a nonprofit, restructure was never. So I'm not optimistic on that. But I am quite optimistic that we can continue to challenge each other and better take care of members and patients. And how do we just help people at the end of the day? So if you were on the other side, if you're a health plan or a broker, how much are you paying for imaging and surgery? Do you have the right providers in there? Are you actually aligned incentives? Last thing I'll say on this slide is one of the #1 barriers to a patient doing even just physical therapy in the traditional fee-for-service world is the copay. And why is that? If the average, let's say physical therapy, let's say you need to do 10 visits to achieve your goals. And the average copay, let's say, is $30. 30 times 10 is $300. The average American can't afford $300. So they'll drop out. So if you look at fee-for-service data versus value-based care data, you'll have a lot of patients drop out after the second visit on fee-for-service. And if you call and interview them, I can't afford it, doc. I can't afford it. So another part of doing any of these things right is to also, if we're going to be really patient-centric, is to really think about the person at the end of the day. Like the patient does not care what the health plan has to pay for the care. They only care about their own cost share. So if we've put up cost share that blocks people from doing the appropriate care pathway, that's crazy. The number of health plans where it's cheaper to just skip non-operative care from the patient's point of view and just get a surgery is mind-boggling. That the benefit design actually promotes more unnecessary surgery than it does non-operative care. Not all plans are like that, but getting people to think through their basic benefit design and really think about what patient Mary is going through on a day-to-day basis and what she can afford and what she's likely to do is required to do this well. So at the end of the day, all these changes help keep people out of the operating room, as you saw, only 0.2%. That's a wonderful thing. Surgery has its place, but it needs to be used responsibly.
Our next session focuses on fixing cardiology. Much like the MSK iceberg that we just discussed, cardiovascular disease often has a massive undiagnosed base below the surface. Patients who are asymptomatic and unmonitored until a crisis hits. To show us how we move from these reactive crisis responses to orchestrated proactive care, please welcome Dr. Jeff Wessler, founder of Heartbeat Health. Dr. Wessler will walk us through how virtual cardiology and the Heart Hero care coordination layer can extend PCP capacity and reduce cardiac readmissions by over 50%. Please join me in welcoming Dr. Jeff Wessler for Heartbeat, from fragmented visits to accountable outcomes.
All right, excellent. Thank you, Tiffany, for that introduction, and it's a pleasure to be here and get to spend a few minutes talking with this group and sharing a little bit about our story with cardiology and virtual cardiology. So, as Tiffany mentioned, I'm a general cardiologist based out of the New York area, and about 8 years ago, started this journey to build a virtual cardiology or a telehealth practice focused on cardiovascular disease and really managing back then what we saw as a growing and increasingly a gigantic cliff we were headed off, where we did not have enough access for cardiac patients across the U.S. I think when we started this medical group and our practice model, what was clear to us is that the model of delivering care for cardiology really had a long way to go and needed to evolve in order to allow patients who needed cardiac care and to see their cardiologist to be able to access those specialists in a timely manner. And so we built up a medical group that I'm going to share with you today and really talk about how this model has evolved over the last few years to help manage patients across the US, in particular with our primary care counterparts and with large risk-bearing groups and provider groups across the country. I've titled this talk From Fragmented Visits to Accountable Outcomes. One of the things that's been core to our model at Heartbeat Health has been lead with evidence and bring data and outcomes to the table to really show that the care that we're doing works and not just hope that it can build a good business model, but actually can deliver and develop these outcomes. And I think this has been a core value of our company, and I'll try to demonstrate some of how what we've built has really come from following the data and the evidence and the outcomes here. So if we start with this problem that we identified, unfortunately, it's only been growing over the past decade. And there are a few different areas that I'd like to highlight here. The first is just the burden of cardiovascular disease. It's remains the number one cause of death worldwide. It unfortunately kills more people than all cancers combined. And the risk factors and the leading indicators of cardiovascular disease are just getting worse and worse time over time. We thought we hit somewhat of a plateau a few years back, but we've started to see that curve go up again as risk factors, in particular cardiometabolic disease, is on the rise. And this has become a predictably incredibly high burden condition for almost everyone living in the US. We've got about 50% of adults suffering from one cardiovascular condition. The costs are just enormous. It's annually a $4 billion problem, and the total cost of cardiovascular care in the next decade will rise to over $2 trillion. And then the majority of deaths and comorbidities in the cardiac space really stem from heart failure, from arrhythmias, and then hypertensive heart disease, which includes coronary disease. These are predictable and in many cases preventable conditions, as I'll talk about in a couple slides, if we can find them and get to them earlier. The problem, as you can see from the map in the back of this slide, is that we simply don't have enough clinicians and cardiovascular clinicians to care for this growing burden of disease. In about half of US counties across the country, there are zero practicing cardiologists. And you can see in the orange blots on the map in the back there, those are all counties with zero cardiologists. The rest have at least one, which means that it's no surprise that we can see wait times to see a cardiologist spanning upwards of several months. And in such a high risk, high concern condition set, this really leads to pretty detrimental outcomes and is core to the problem that we aimed to solve here at Heartbeat. So if you think about the way that our existing cardiac system and cardiovascular care system works, you have the diagnosed patients who are at the top here, those with symptoms, and these are the patients that are usually receiving all of our services today. These are your patients with heart attacks and strokes and heart failure hospitalizations that are coming in and out of the hospital and receiving advanced interventions. Unfortunately, it's those below the surface, the undiagnosed, that are both asymptomatic and unmonitored, that are really the building burden here that we have to find a way to get in front of if we're going to prevent the stroke or the heart attack from happening in the first place. And these are conditions that all have now very strong ways of finding them early, things like heart failure, diabetes, obesity, high blood pressure, including respiratory conditions, and those with abnormal findings on some of their imaging tests. We don't do a good enough job of looking for and finding these conditions, but when we do, we can really make a big difference in the trajectory of that progression of the disease, and that makes a huge impact on a per patient level. Now, why does all this matter? Well, of course, finding patients earlier is important to halt that progression of disease, but it's also the case that this proactive and predictive care can actually really stave off the downstream progression all the way through expensive hospitalizations. And so this chart here is meant to illustrate the time point in which you start managing a patient makes a huge difference in the cost profile and how we're able to deploy resources to actually manage these patients. And often these take place at very different sites. So if you see on the right, we have hospitalization, emergency room. The middle is our usual presentation at cardiology. But if you go upstream of that, when patients are presenting at primary care, or even pop health programs that manage patients at primary care, even before they're presenting to the office, you have a real opportunity to shift the site of service here, to shift the stage at which we're getting in front of this disease. And when we started seeing our care being done in particular with some of these scaled primary care programs across the country, we really started to see this model in action and began to focus a lot of our efforts on shifting more toward the green, toward lower cost early detection care. Excuse me. So here's what we've built at Heartbeat today. We're a 50-state medical group with complete care for cardiopulmonary issues. We have seen over 1 million patients, have a very large clinical team of several hundred folks with over 1,000 provider licenses across the country. And the services we do, I've listed on the right here, as well as some of the models we work with, but I'll just talk through a few of the key assets we have. So when you think of a cardiology practice, Heartbeat looks a lot like what you might be thinking of, with two major exceptions. Number one, we don't have any brick and mortar assets of our own, so we don't have offices all over the country. Instead, our clinicians uh, are usually working from home or in their offices and caring for patients who are in their homes. So the patients are not coming into a cardiology office. We don't have any brick and mortar. There's some exception to that in that we do staff sonographers, who are the folks who do echocardiograms. But other than that, we don't really have offices or brick and mortar assets there. And the other main difference compared to a normal or traditional practice is that a Heartbeat practice always works on behalf of another group, which is usually an accountable care or risk-bearing provider group. And the reason that we've built this model up is that we've felt that the need in the market and the opportunity in the market was really working directly with provider groups, many of which have some cardiology or and some of which have limited or no cardiology, but certainly have patients that have high needs for cardiology, and therefore have the opportunity to really embed a virtual care model like ours in their system to help with the early diagnosis and care of these patients before they get to the advanced side of that curve. And the way that we've deployed and rolled out our services are twofold. The first are these condition-based programs, and I'll talk about those in 1 second. And the second are on the identification and closing of gaps of care. So if we start with the condition-based programs, excuse me, we have 3 major programs that we've rolled out. The first is around heart failure. Now, heart failure is a condition that really means that you have structural changes in the heart that don't allow it to pump blood forward with as much strength as it needs to get to the rest of the body. And this usually happens because of some damage in the heart muscle. So finding it early is really important because then you can get patients on the medications that they need in order to prevent that progression all the way forward as the disease advances. The way that we deploy these programs at Heartbeat is by rolling out early identification of heart failure, which is called stage B heart failure. And the way that we do this is take a group of patients who are at risk for heart failure, get them an echocardiogram, as well as any other diagnostic testing they may need, identify and diagnose the condition of heart failure, and then, depending on the findings that they have, either hand the care plan back to the primary care to manage, or if they have really clinically significant findings, then we'll do virtual care and manage these patients with medications to actually care for and treat their heart failure and prevent it from progressing. We follow this same model across arrhythmias. So arrhythmias, which are things like atrial fibrillation, supraventricular tachycardias, ventricular arrhythmias, all of these are heart rhythm issues that require a rhythm monitor in order to diagnose and identify these. We take the same model of taking patients who are at risk for these conditions, get them a diagnostic test, which is usually a rhythm monitor that's a 14-day patch that these patients will wear, and then take the results of those, and depending on the findings, either hand a care plan right back to the primary care team, or if patient has advanced findings, we'll manage, order, titrate medications like stroke prevention, rate control, antiarrhythmic agents in order to keep their condition at bay. So this does two things. Number one, it identifies the actual disease, which is critically important for any risk population. If you're bearing risk on them, you need to know and want to know which conditions they have. But then it also keeps them at the stable side of the disease so that they're not going into the hospital and bouncing in and out of high acuity facilities, but rather being able to be managed at the primary care setting or at their home to keep them in the lowest acuity setting possible. So these condition-based programs have been very successful, both for our primary care partners, but also for the patients and the populations we're managing, in order to really identify, but then keep the conditions at the lowest level possible, and then manage aggressively with medications before a condition gets out of hand. What you see here is what we've termed wraparound care, which is the clinical care pathway schema that I just laid out, where we work closely with a primary care practice or provider group, identify those who are at high risk for a condition, get them the diagnostic, which is usually an echocardiogram or a rhythm monitor, and then risk stratify based on the findings, where we'll put someone in a normal, low, high risk, or emergent bucket. And all of that care can be certainly customized to the practice, but usually ends up either with usual primary care continuing, which is about a third of the cases, an e-consult or peer-to-peer asynchronous report, which we hand back to the primary care in about a third of the cases, and then televisits with our team in about a third of the cases for those who have high risk or emergent findings as well. So here's an example of a patient journey that I'll talk about and walk you through what happens in the traditional setting with this patient and what happens with Heartbeat's journey. So this patient is a 55-year-old with longstanding risk factors, obesity and hypertension, who has not had a lot of interactions with the health system at all. In the traditional system, what will often happen with this patient is he'll progress until he develops symptoms, often head to the emergency room for his first point of care, where he'll have a advanced workup, get some imaging tests. In this case, he would be diagnosed with heart failure, started on medications and then be discharged with a follow-up for cardiology. Contrast this to the heartbeat journey where in collaboration with our primary care partners, we'll identify a patient early as being eligible for a program like our heart failure program, get an early diagnostic like an echocardiogram that can diagnose stage B or earlier heart failure, and ultimately start the medications that will prevent the progression to stage C or symptomatic heart failure, in which the patient's bouncing in and out of the hospital. And it's the key here is that this is a condition that actually can be managed the earlier you find it, and can be the progression can be halted the earlier you find it. Those are the key aspects of any of our programs that we run to make sure this is not just screening for screening's sake, but actually finding disease that can be and will become high risk, and therefore needs to be managed to prevent it from becoming high risk. So I'll talk a little bit about how we've built our model and how we've built it in order to work with this high risk and often elderly population. When we first started back in 2017, 18, 19, this was in the early telehealth days. We had to learn the hard way that you really need to build a technology-free layer, meaning there can be almost no footprint of tech that interferes or creates friction with our patients. So we abandon our app, we abandon all passwords. There's nothing to install, no accounts to create. This is really a tech light flow. A patient gets, in the case of a telehealth visit, an SMS or an email that goes directly into our waiting room. So there's no need to download or remember your passwords or anything like that. And over the years, as our tech has got better, the patient user experience has gotten easier and easier. We've basically gotten rid of everything that could become an impediment to a patient ending up on this video visit with our provider groups. And that's been really key to allow this to be an experience that actually works for the patients we serve, rather than one that works in theory but can never actually get to the patients. And we've invested as a result of this pretty heavily in automating a few of the processes that have become necessary to manage this at scale. So we do a lot on the risk classification to take a patient's chart and their comorbidities and assess their risk based on the diagnostic findings. We have a lot of conditional logic to actually route patients to the right care based on their risk classification. And this is key because utilization becomes really table stakes for a program like this. You don't want you don't want any new specialist program just to drive up utilization of services. You really want it to only uh, offer the patients and the providers the services that are really most necessary. And so when we roll out a program like this at scale, we want to make sure that only those who need televisits, for example, are getting televisits, but everyone else can get an asynchronous care plan. Interoperability is obviously a key part of any integration with multiple provider groups. So we've invested heavily in making sure that we can seamlessly get our data into the provider and often the primary care system and partner systems, regardless of what EMR they're on and how their integration capabilities work. And then patient record retrieval has become very important for us because we're seeing so many patients from across so many different offices and clinics and systems. We need to make sure that we know enough about the patient to do safe, high quality care. And this has been a large investment of ours to make sure we get all of the right records for a patient before that visit begins. And then lastly, uh, patient notification and making sure that folks who are about to be seen get the proper reminders so that we're not wasting any time and don't have a high no-show rate, has gotten so much better over the years and been really key for our partners who really want to know when they're bringing a patient into our program that that patient will be seen, and we want to do everything we can to get that care to the right patient. So the last thing I'll talk about before I go through a few of our outcomes and then open up for questions is our Heart Hero group. So about, I think 6 years ago, as the practice was getting going, we had this insight that really so much of the care journey with a virtual practice was actually powered by the team of medical assistants and care coordinators who do all of the interim work in between visits. And so we named this group and the Heart Heroes, and really gave them a role to fill, which was everything you see here, managing every aspect of this patient's care journey, from the initial touch point all the way through the follow-ups and handoffs and diagnostics that they need. And we've come to see the Heart Hero group as being really one of the core differentiators that our practice has as a virtual care practice. Uh, as compared to a brick and mortar, or I now call it a terrestrial practice, a virtual practice has many more uh, coordination touch points that need to happen, because it's not all happening in one setting in an office. And so the Heart Hero team has really been the cornerstone to that. Most patients will identify their Heart Heroes by name and say just how amazingly helpful they've been. And our Heart Heroes similarly talk about the patient relationships that they've developed along the way. And it's become a really core asset to this program, and one that I'm really proud of, and has really helped make our to this program, and one that I'm really proud of, and has really helped make our coordination with the patients, the primary care groups that we work with, work quite well. So I'll finish here by just sharing a little bit about the outcomes we've seen, and what our impact has been. So across the last 8 years or so, we've had it's been really core to the model that we track everything we're doing, that we keep a good set of data, and bring outcomes to the table, and importantly, publish what we're doing. And over the years, we've maintained a few stats that I'm really pleased to share. The first is a very high NPS. Patient satisfaction is really core to this model. Patients are very happy to be able to get access to cardiologists within a few days from their home. We've gotten members to over 90% of their target blood pressure rates, and over 80% of their statin rates for patients with diabetes. Our heart failure therapy is a, a really strong accomplishment, 51% compared to industry rates, which are often in the 10 to 20% for eligible patients getting on all four of the heart failure drug classes. And then this has amounted to a significant reduction in both all-cause and cardiac hospitalizations or rehospitalizations after discharge. And this data comes from one of our first randomized control studies that we published last year, on a group of patients who were hospitalized for cardiac reasons, discharged, and then randomized either to heartbeat care or routine cardiology care for the following 3 months. And so the care model seems to work quite well. Patients are quite satisfied with it. We've seen a reduction in utilization of expensive and at times unnecessary cardiac services that might happen in a more brick and mortar centric cardiac practice. And then importantly, these outcomes have really amounted to patient a reduction in some of the very serious patient complications, which are key to us being confident that this might actually cause an inflection and begin to plateau the burden of cardiac disease that we're seeing across the country.
As we bring today's conference to a close, I want to take a moment to reflect on the journey that we've taken together. We started this morning with Don Caltagno, who reminded us that in theory, there is no difference between theory and practice, but in the real world where friction does exist, the difference is very huge. We've spent the last few hours looking at exactly how to bridge that gap, moving from fragmented transactional care to truly coordinated networks that drive performance. We've seen a common thread through every session today. Primary care is the new control center. And in the Arista MD and CenterWell session, we saw how asynchronous consultation can turn the 2 islands of primary and specialty care into a single integrated clinical narrative where the PCP stays in the driver's seat. In the Inspira Life Partner Spotlight presentation, Dr. Stefanacci demonstrated that when you are 100% at risk for every dollar and every outcome, closing a 26-day specialist wait gap is a clinical necessity that keeps seniors safe at home. And we also heard the powerful confessions in Confessions of a Spine Surgeon, where Dr. Ryan Grant showed us that interrupting the surgical cascade before it starts is the ultimate act of high-value care. Finally, in this last session with Heartbeat Health, Dr. Jeff Wessler provided that we must look below the tip of the iceberg in cardiology to proactively stabilize patients before they ever reach the hospital. The integrated advantage is no longer just a theoretical strategy. It is a reality built on digital infrastructure and shared clinical context. We're moving toward a future where PCPs are empowered to manage broader clinical terrain. Specialists influence more care than they personally see, and patients experience continuity rather than confusing handoffs. As you all get back to your practices, I want to leave you with the next steps for today's material. As our team is currently editing the recordings of each session to ensure that you have the best possible viewing experience, we will be emailing the full conference recording to everyone next week. Along with the videos, we will include all of the presentation PowerPoints, including Don's presentation, the CenterWell Blueprint, Inspira Life Spotlight, the Confessions of a Spine Surgeon, and Heartbeat Health Spotlight, so you can share these insights with your own teams. Once again, my name is Tiffany Guevara, and it has been an absolute pleasure hosting you today. If you have any remaining questions or need further information, please don't hesitate to email me at info@aristamd.com. Thank you to our incredible speakers and to each one of you for your commitment to transforming healthcare. We look forward to seeing you in our next virtual conference.